Tungkol हेलो हेलो। हाँ, अस्सलाम वालेकुम। अस्सलाम वालेकुम।
जी वालेकुम अस्सलाम रहमतुल्लाह।
अच्छा, आवाज आ रही है मेरी?
जी आवाज़ आ रही है।
स्टार्ट करते हैं।
मधु साहब ज्वाइन हो गए हैं?
जी हाँ सर हैं, मधु सर हैं। बिस्मिल्लाहिर्रहमानिर्रहीम। Respected director sir, my teachers, my seniors, my colleagues and dear students, Assalamu alaikum and a very good morning. Welcome to our third national webinar on ILMUL JARAHAT Updates 2022. We are your hosts, me, Dr. Firdaus Ahmed Najjar, Dr. Majabin Fatima, Dr. Muhammad Shakil Ansari, and Professor Syed Shah Alam, the organizing committee of this today's third webinar on ILMUL JARAHAT Updates 2022. Professor Syed Shah Alam is as chairman organizing committee, and Professor Wadud Sir, Director, National Institute of Unani Medicine, Bangalore, is heading the webinar as patron of today's program. Dear participants, today's webinar, this third webinar, is also a part of celebrations of Azadi Ka Amrit Mahotsav. In our last two webinars held in March and April, we had two lectures in each webinar. Alhamdulillah, we have received a good response from our participants who had joined us and who had watched these programs. Today's program will also consist of two lectures. Today, the schedule of the program is as today's schedule is as welcome address by Professor Syed Shah Alam, followed by the address by Director Sir, Professor Wadud Sir. Then there will be two lectures. After every lecture, enough time will be given to the participants to interact with the speakers. And after ending second lecture, there will be vote of thanks by Dr. Majabin Fatima. Dear participants, my request is to mute yourself during the lecture. After the lecture, you will get time to put your queries if any. Dear participants, we are joined by our director, sir. We are joined by our teachers, faculties, and participants from abroad. So let us take this opportunity to welcome our participants and guests in this program. For welcome address, I will invite Professor Syed Shah Alam, Chairman Organizing Committee of this webinar. Professor Syed Shah Alam.
Thank you, Dr. Firdaus. Assalamu alaikum warahmatullahi wabarakatuh.
Walaikum assalam.
I am thoroughly pleased to witness you all here. It is a moment of extreme pleasure to welcome the guests who are present here to attend this one-day national webinar as a part of celebration of Azadi Ka Amrit Mahotsav. On behalf of the organizing committee, I welcome to all the participants who have joined the one-day national webinar on ILMUL JARAHAT Updates 2022. Particularly our beloved director, Professor Abdul Wadud Sir, for managing time out of his busy schedule. I bid a very warm welcome to today's speakers also. Associate Professor ZGM Unani Medical College, and Dr. Muhammad Shakil Ansari, Assistant Professor, NIM, Bangalore. I welcome all our teachers, faculties, colleagues, and students who have joined us. We all have gathered here today to attend this one-day national webinar based on Enhance Our Knowledge. This series of webinars intend to resolve the practical hurdles faced by the doctors and practitioners. Today's webinar will cover two important topics on urolithiasis and thyroidectomy. Both the topics are of great surgical importance. This webinar will throw light on different aspects of urolithiasis and thyroidectomy. Therefore, I'm sure this webinar will be meaningful and thought-providing and useful to all the participants. Therefore, I am sure this webinar will be meaningful. I once again welcome one and all who are with us. Without any further delay, like to start this event, we would be delighted to have your suggestions and questions at the end of the event. Thank you again, one and all. Thank you.
Thank you, sir. Thank you very much. I once again request the participants to mute yourself while during this talk.
हाँ उसे ऑन किया मैंने.
Dr. Manzoor, please mute yourself. Dr. Manzoor, please mute yourself till.
Yeah. Okay.
Thank you, participants and guests. Thank you, sir. Now there is time to listen to our director, sir, Professor Wadud, sir. He has joined us already. He will address the gathering. Sir, Professor Wadud, sir, please.
आवाज आ रही?
जी सर, आ रही है.
Okay. Thank you. Assalamu alaikum. A very good morning to all of you.
Walaikum salam, sir.
My colleagues and teachers of Department of ILMUL JARAHAT, Professor Sayyid Shah Alam, head of the department, and a very handsome personality and a very good surgeon, Dr. Manzoor Ahmed, our speaker from outside, all the participants, students. This is, as told by Dr. Najar, it is third national webinar organized by the Department of ILMUL JARAHAT. This is a series we have started to deliberate lectures on certain topics, and I have given the task to all departments to organize at least 4 webinars, national or local webinars. Alhamdulillah, Department of ILMUL JARAHAT is far ahead of all the departments. It is third of its kind. The department continuously organizing such programs, whether it is a training program or webinar or lecture series. This department is a prestigious department of National Institute of Unani Medicine, and since its inception, the department is continuously progressing by the effort of its HOD, Professor Sayyid Shah Alam, and his team. They are hardworking. Continuously, they are putting their effort for the development of Department of ILMUL JARAHAT, and the institute is giving all kinds of support for the development of this department. This department also contributing a lot in increasing the number of patients in the institute. It has a very good share of our hospital statistics, and not only in terms of its good work, the very good infrastructure has also been developed by the effort of this team of the Department of ILMUL JARAHAT. I'm very happy with this department. I hope in future this department will also further progress and will organize such type of programs. Thank you.
Thank you, sir. Thank you, sir. Inshallah, sir, we will come up with your expectations, inshallah, sir. And thank you for your appreciating and encouraging words. Surely, sir, we will try to come up with according to your expectation, inshallah. Now, moving ahead towards our this topic today, we have 2 top speakers today, Dr. Manzoor Ahmed from Pune and Dr. Muhammad Shakil Ansari from our department. They will cover 2 different topics. One is urolithiasis and the second one is thyroidectomy. Our first talk will be on urolithiasis by Dr. Manzoor Ahmed from Pune. Their participants' urolithiasis is increasing commonly in with a rate of approximately 12% worldwide, and it is associated with an enhanced risk of end-stage renal disease. Most of the time, it is very painful, which disturbs the daily routine of the patients and as well the quality of the life. How these stones are formed and what is the presentation of these stones, and most important, how a patient with urolithiasis can be managed at different stages by different modes of treatment. To understand all these things, we have invited our first speaker today, Dr. Manzoor Ahmed, Associate Professor, ZVM Unani Medical College, Pune. Dr. Manzoor Ahmed has done his BSc. After that, he has joined Ajmal Khan Tibia College, Aligarh Muslim University for his graduation in Unani Medicine. After completing Unani Medicine, graduation in Unani Medicine, he did his Masters in Surgery from Ajmal Khan Tipia College, Department of ILMUL JARAHAT, AMU. He completed his master's in 2022 from AMU and joined ZVM Unani Medical College, Pune in 2003 as assistant professor in surgery. In 2028, he was promoted as associate professor, Department of ILMUL JARAHAT, ZVM Unani Medical College, Pune. Dr. Manzoor had compiled a book on leech therapy and modern surgery in 2011. He had many publications to his credit, and Dr. Manzoor had also received a national award, Ibn Sina National Award in 2018 from AMU Aligarh. Dr. Manzoor is an enthusiastic surgeon, a successful surgeon. He has done thousands of surgeries, minor and major cases. With these words, I will invite Dr. Manzoor to start his talk on Euro-V cases. Dr. Manzoor Ahmed.
Assalamu alaikum to all.
Wa alaikum assalam.
Myself, Dr. Manzoor Ahmed, and thank you very much to authorities, director, head of the department of ILMUL JARAHAT, Dr. Shalam, and director Dr. Abdul Wadud Sahab, to give me an opportunity to take a lecture on urolithiasis and its management. Actually, there is a little problem to connect the display of my PPT. During this period, just
You have to share the screen.
start.
You share
Yes,
the
yes.
screen. Simply, it will
Just
be,
I am.
it will be displayed, inshallah.
Inshallah. Share. Share. So urolithiasis and its management. This is my topic. The objectives of my lecture is just to know the etiopathogenesis of stone formation in urinary system, to understand management of urolithiasis according to etiopathogenesis of stone formation, to avoid the recurrence of the disease. The next thing is how to diagnose and to understand surgical management of urolithiasis. Now we'll discuss about the etiology, the genetics. The 25% of family history, age is usually 20 to 40 years of the age, and there is a ratio in between male and female is 3:1. The geographical distribution of the disease is the disease is very common at the mountaineers and who are living in desert and tropical areas. And the disease is usually recur during the summer months. The water intake is very important factor of the urolithiasis. The low water intake. Actually, the increased water intake is favoring the increased urine output, which decreases the incidence of urolithiasis. Same, you know. So we have to take, the patient must have to take to 2-3 liters per day water intake is recommended. The diet, ingestion of high amount of purines, oxalate and calcium phosphate. These things may
Manju sir,
aggravate.
change the slide.
अरे नहीं हो रही है चेंज इसमें कुछ गड़बड़ हो रहा है just wait one minute. Actually, there is a problem in the display. Slide. During this period, I want to discuss the disease is actually multifactorial. There is no only single factors which is responsible to form the stone.
पता नहीं क्यों प्रॉब्लम शेयर स्क्रीन में तो चलता रहता है सही आराम से आपके में कोई दिक्कत नहीं है इकबाल साहब वाले में हुई थी मंजूर उधर उनके भी उसमें हुई थी
This is my request to kindly mute all the microphones.
शायद हाँ
Kindly mute all the microphones. किसी का microphone on है हाँ okay. So I was discussing about the disease. Actually, this is very important to understand the etiopathogenesis of so this is very important to understand the etiopathogenesis of the disease just to avoid the recurrence of the disease, because this is very common problem. We are going to operate this disease means urinary stone, and later on the patient is coming to the OPD and along with the same complaints and same problem, including the same report of the investigations ki there is a stone in the kidney or there is a stone in the ureter and all that. So that is very problematic thing. At that time उस वक्त ऐसा लगता है कि यार अब क्या करूं मैं, है ना, पेशेंट को ऐसा we cannot उसको पेशेंट को समझाना जरा मुश्किल हो जाता है कि साहब क्यों ऐसा हो गया है. इसलिए we must have to understand the etiopatology of the disease just to avoid the recurrence. Okay, so first of all we have to understand that this is a multifactorial disease. Means there is a plenty of the factors working together, then the stone is forming. Otherwise there is no chance of the stone formation. I will discuss the thing. So the disease is very common during the summer months and water intake. All these things we understand. There is an increased water intake, there is an increased urine output, and there will be decreased incidence of the urolithiasis. So we have to take at least 2 to 3 liters per day. Okay. Now other things regarding diet, ingestion of high amount of the purines, oxalate and calcium phosphate. These things are aggravating the formation of the stone. The other thing is vitamin A deficiency, as we know. Okay. The next thing is occupation. Increased incidence in the administrative professionals, sedentary professionals and managerial professionals. ये 3 jobs ऐसी हैं जिसमें जो है कहते हैं इंसिडेंस बढ़ा हुआ मिला है हमारे रिसर्चेस में. The other things is stress is causing increased incidence and prolonged immobilization resulting in the skeletal decalcification, which is resulting in the hypercalcemia, and that hypercalcemia is causing the stone formation. The Randall's plaque. The Randall has discovered a type of the plaque which is giving a source, which is giving a stay of the crystals to coalesce the plenty of the crystals. There will be aggregation of the crystals for the stone formation. Now I will discuss the urinary calculus formation. The step 1, there should be supersaturation of the urinary solutes. The step 2, there should be a crystallization of the soluble products. The next step is crystal growth. Means first of all, there should be a crystallization of the soluble products. Then this crystal will be grow. Okay. And all the crystal is usually growing in absence of one of the inhibitors. I will discuss later on about the inhibitors. So there will be no crystal growth if there is a presence of the inhibitors. So the role of inhibitors is very important. The next step is there should be a crystal aggregation. Again, there is a very important role of the inhibitors regarding during the crystal aggregation. The step 5, there should be all these factors are there, but if there is no obstructive phenomena of the urinary tract or urinary system, so there is no chance of the stone formation. Okay. Means there will be formation of the crystals, there will be crystal growth and there will be crystal aggregation, but these crystals and aggregated crystals possibly are passing out through the urinary system, from the urinary system. But if there is any obstructive phenomena in the urinary system, that is favoring the stone formation. Now we have to understand about the stone formation. There should be crystals along with matrix and obstructive tract. ये 3 चीजें होना बहुत जरूरी है कि सबसे पहले तो क्रिस्टल्स का बनना, उसके बाद वहां पर मैट्रिक्स का होना और फिर ऑब्स्ट्रक्टिव ट्रैक भी होना चाहिए, तभी स्टोन फॉर्म होगा. अदरवाइज स्टोन फॉर्मेशन के चांसेस बहुत कम हो जाते हैं. और क्रिस्टल एग्रीगेशन कैसे होगा? मींस अगर मैट्रिक्स अवेलेबल नहीं हुआ तो देयर विल बी नो क्रिस्टल एग्रीगेशन. और साथ साथ में इनहिबिटर्स का एब्सेंस होना चाहिए, यानी देयर इज अ क्रिस्टल्स and matrix is also available, but for crystal aggregation there should be absence of inhibitors, and after the crystal aggregation in presence of obstructive tract there will be stone formation. Now we should understand about the physical chemistry of the stone formation. There should be a supersaturation of the solutes, first step. However, the urine is metastable of the calcium oxalate, and urine is very complex solution. Means there is a buffer solution. Means अगर वहां पर सुपर सैचुरेशन सल्यूट्स का हो भी रहा है तो वो जो है कहते हैं, चूंकि यूरिन एक बफर सोल्यूशन है तो वो बफर करके सुपर सैचुरेशन को भी कंट्रोल कर लेता है, यानी उसके बाद भी उसको चांस देता है। ओके, बफर सिस्टम, बफर फिनोमेना हम लोग सब समझते हैं। नाउ वी विल डिस्कस अबाउट द यूरिनरी कैल्कुलाई. As we know, calcium oxalate, calcium phosphate, triple phosphate or steroid stone, urate, calcium urate, cysteine and xanthine. Cysteine, xanthine and urate, they are metabolic stones. Cysteine or xanthine are forming through the amino acids. Now we'll discuss about the calcium oxalate. There are two types of the calcium oxalate stone, the calcium oxalate monohydrate and the calcium oxalate dihydrate, which is very common urinary stone. This is hardest and having spicules and usually dark brown in color because of the blood stain. Calcium phosphate. Now there's a plenty, about 6 types of the calcium phosphate stones. The calcium hydrogen phosphate dihydrate, the hydroxyapatite carbonate, tricalcium phosphate, octacalcium phosphate, and magnesium hydrogen phosphate trihydrate, and magnesium means calcium magnesium ammonium phosphate, which is known as triple phosphate. Calcium magnesium ammonium phosphate hexahydrate, which is also known as steroid stone. Now we'll discuss about the urinary calculus formation. The first step regarding the crystallization, just I want to share with you कि if there is a calcium is combining with the oxalate, there will be a crystal formation. But if the calcium is combining with the citrate, that is liquid. Okay. Now stone formation, urine should be super saturated, and the other factor should be there. There is an absence of inhibitors. Inhibitors of calcium crystal formation, inhibitors of crystal growth, and inhibitors of crystal aggregation. Now we'll discuss about the inhibitors. The low molecular inhibitors of crystal growth, which is very well known, citrate and pyrophosphate. Now we'll discuss about the large molecular inhibitors of crystal aggregation, which is glycosamine, glycans, and nephrocalcine, and horsefall protein. Now I'll discuss about the pathophysiology of the stone formation. The calcium oxalate is usually forming because of there is a plenty of factors. There should be hypercalciuria, there may be a hypercalcemia, then there should be a hyperoxaluria, there should be hyperuricosuriia, and there should be hyposecreturia. So these 5 factors should be there: hypercalciuria, hypercalcemia, hyperoxaluria, hyperuricosuriia, and hyposecreturia. Now I'll discuss about the hypercalciuria. About 30 to 60% patients are showing hypercalciuria even with no hypercalcemic status. यानी about 30 to 60% पेशेंट ऐसे होते हैं जो हाइपरकैल्सियूरिया शो करते हैं, हालांकि उनको हाइपरकैल्सीमिया नहीं होता है. क्यों ऐसा होता है? Because of the absorptive hypercalciuria, increased intestinal absorption of calcium. The other is renal hypercalciuria, which is primary renal leak of the calcium, and the resorptive hypercalciuria, there is an increased bone demineralization and idiopathy. Now we will discuss about the hypercalcemia. Hyperparathyroidism, which is very well known recurrent, very well known cause of the recurrent urolithiasis, and treatment is ultimate treatment is surgical removal of the parathyroid gland. The other factors are sarcoidosis, granulomatous disease, hyperthyroidism, glucocorticoid steroid induced, and pheochromocytoma. Prolonged immobilization, patients of paralysis, coma, lower limb fracture, and there is a iatrogenic causes of the hypercalcemia are also there. Thiazide induced, commonly used as antihypertensive drug, estrogen therapy, which is used in carcinoma of breast and carcinoma of prostate, And anti-estrogen therapy is also causing hypercalcemia, which is also used in CA breast and CA prostate. The treatment is blood volume expansion, means excessive fluid, or IV normal saline, biophosphorates, any pamidronate, IV, and calcitonin, whether we have to give IM or subcutaneous. Now we'll discuss about the hyperoxaluria, how the hyperoxaluria is there. Battery lower. Genetic production of oxalate. Genetic cause is hepatic production of oxalate. Entry cause is short bowel disease and increased transport of oxalate from RBCs. Metabolic cause is diet. Treatment of hyperoxaluria, we should control the dietary calcium, pyridoxine, and pyridoxine decreases urinary oxalate excretion, and thiazide, which is also decreases urinary oxalate excretion. Hyperuricosurium, usually caused by high ingestion of purines, resulting in hyperuricosurium. Uric acid increases calcium oxalate crystallization, and uric acid and calcium urate stone formation. Management of hyperuricosurium: dietary proteins restriction, red meat, chicken, fish, and all that. Allopurinol is a very well-known drug for the treatment of hyperuricosurium, which activates xanthine oxidase and decreases uric acid synthesis. Hypocytraturia, distal venal tuberculosis. Hypocytraturia के causes, there is a distal renal tubular acidosis and chronic diarrheal syndrome. Thiazide drug as an antihypertensive use. There may be hypocytraturia idiopathic, which is caused by high animal diet, strenuous physical exercises, increased sodium intake, active recurrent UTI, and intestinal malabsorption of citrate. The management of hypocytraturia is correction of cause and oral ingestion of citrate. Now will come hypomagnesemia. The inflammatory bowel disease is associated with malabsorption of magnesium, and management is oral magnesium citrate. Steroid formation, steroid stone formation. The steroid crystallization is actually favored by urine if the urine pH is more than 7.2, means if the urine is alkaline, there may be a favor to steroid crystallization. And the other is urease producing bacteria. ये दो फैक्टर्स ऐसे हैं जो स्टेरॉइड क्रिस्टलाइजेशन को फेवर करते हैं. You are seeing there is a staghorn calculus formation, and this staghorn is usually forming through the steroid stone. Okay, and this staghorn calculus is usually silent killer of the kidney. बहुत मरतबा हमारे पास पेशेंट्स आते हैं ऐसे जो स्टैगहॉर्न के जो है कहते हैं कंप्लेंट मिस स्टैगहॉर्न के रिपोर्ट्स लेकर आते हैं, और जब हम फर्दर वर्कआउट करते हैं तो पता चलता है कि उनकी किडनी डेड हो चुकी है. सो द मैनेजमेंट ऑफ स्टेरॉइड स्टोन is staghorn stone. The surgical treatment is PCNL plus ESWL, antibiotic therapy, acetohydroxymic acid, which is potent irreversible inhibitor of urease, and irrigation and chemolysis. Dissolution of calculi along with irrigation under control of infection. Now we'll discuss about the clinical presentation of all the types of the stones. Most of the time, the patient is coming with the history of stone, but asymptomatic. On investigation, you are finding out there is a stone in the kidney. Okay. So asymptomatic patients are very dangerous because if there is a staghorn stone which is blocking the entire pelvic calyceal system, that may cause the death of the kidney. पूरी किडनी जो है नॉन फंक्शनल हो जाती है ऐसे स्टोन से. तो स्टैगहॉर्न टाइप के जो स्टोन होते हैं वो अक्सर एसिम्प्टोमेटिक होते हैं. मैं कई पेशेंट्स को जो है कहते हैं मिस मैनेज किया मैंने, और फाइनली जो है कहते हैं जब वर्कआउट करने के बाद पता चला कि उनकी किडनी नॉन फंक्शनल हो चुकी है. द अदर सिम्टम, वेरी कॉमन सिम्टम इज दैट इज पेन. The site of the pain is loin. The nature may be fixed or colicky. Colicky pain usually कब होता है? जब कैलिसेस में स्टोन हो, या फिर जो है कहते हैं यूरेटर में स्टोन हो, या फिर किसी वजह से भी वो ऑब्स्ट्रक्शन कॉज कर रहा है. Then this pain is radiating to the groin. Aggravating factor of the pain is jumping movement and usually relieved by injectable NSAIDs. Hematuria, there may be a gross hematuria or there may be a microscopic hematuria. This pain may be associated with cystitis-like clinical features, burning micturition, urgency of micturition, and on examination there may be a tenderness at loin. There may be a tenderness at flanks also, especially during the acute attack of the pain. जब भी कोई पेशेंट जो है पेन की कंप्लेंट लेकर आता है उस वक्त तो टेंडरनेस मिलती है, बाद में टेंडरनेस नहीं मिलती. Sites of obstruction in urinary tract, as we know, the calyces, the PUJ, pelvic-ureteric junction, the crossing of iliac vessels, the crossing of vas deferens and round ligament, or entry of urinary bladder and vesico-ureteric junction. Now I'll discuss about the clinical features of ureteric calculus. The colicky pain varies according to the position of ureteric calculus. Upper 1/3, if the ureter is divided, ureter is divided in upper 1/3, middle 1/3 and lower 1/3. तो अपर 1/3 में जो है कहते हैं लॉइन से यूजली लंबर में जो है कहते हैं रेडिएट करता है या ग्रॉइन में रेडिएट करता है, और मिडिल 1/3 में लंबर से जो है कहते हैं ग्रॉइन में रेडिएट करता है, जबकि लोअर 1/3 से इलियक फॉसा से ग्रॉइन में रेडिएट करता है. Investigations, as we know, the urine should be sent for routine and microscopic. Radiography में X-ray abdomen KUB कराएंगे, which is diagnostic investigation, and intravenous urography. USG abdomen is nowadays routine investigation, just to find out the stone in urinary system, and sometimes there is a need of the CT scan abdomen or MRI abdomen. Otherwise, these investigations are enough to manage the patient. यूरिन में शो करेगा, यूरिन में क्रिस्टल्स, आरबीसीज और उसका पीएच, ये तीन चीजें हमको देखनी है. अगर उसमें क्रिस्टल्स और आरबीसीज हैं, इट मींस कि स्टोन फॉर्मेशन की शुरुआत हो गई है, यानी क्रिस्टलाइजेशन तो हो चुका है एटलीस्ट. एंड देयर मे बी अ क्रिस्टल एग्रीगेशन आल्सो एंड देयर मे बी अ स्मॉल साइज स्टोन आल्सो. इसी वजह से आरबीसीज भी आ रही हैं. एंड पीएच इज वेरी इंपॉर्टेंट टू नो. एक्सरे एब्डोमेन KUB यूजुअली जो है कहते हैं प्रिपरेशन के बाद कराना चाहिए, तो क्लियर पिक्चर आती है. और एक्सरे एब्डोमेन KUB के रिजल्ट में जो है रेडियो ओपैक शेडो एट यूरिनल और यूरेट्रिक एरिया और यूरिनरी ब्लैडर एरिया में दिखाई देगी. Then we have to go for urography, which defines anatomy as well as physiology of the urinary system. And urography में IVU and retrograde cystography. Now we will discuss about the management of urolithiasis, which depends on the location of इसमें नहीं है. So management of the urolithiasis, usually it depends on the size of the stone. First of all, ये disconnect नहीं हुआ है. If the size of the stone is very small, means if the size of the stone is if the size of the stone is very small, means it is less than 5 mm or it may be up to the 7 mm. So there should be a medical management of the stone. और मेडिकल मैनेजमेंट में जो हमारे पास दवाएं हैं, जो कि मशहूर दवाएं हैं और हम उनके बारे में खूब अच्छी तरह से जानते हैं, इनमें जो है कुछ दवाओं पे रिसर्च वर्क हो चुका है. वो रिसर्च वर्क में जो दवाएं प्रूवन है वो है शरबत बुजूरी मोतदिल और शरबत आलू बालू. शरबत बुजूरी मोतदिल पे डॉक्टर जुल्किफ्ल, जो नेशनल इंस्टीट्यूट ऑफ यूनानी मेडिसिन में प्रोफेसर हैं, उन्होंने किया था और सिग्निफिकेंट जो है कहते हैं रिजल्ट उन्होंने दिया कि देयर इज अ मैनेजमेंट ऑफ द हाइपोसेक्रेटूरिया. हाइपोसेक्रेटूरिया वो किसी भी टाइप का हो, कोई भी कॉज से हो, वो हाइपोसेक्रेटूरिया जो है कहते हैं उससे बहुत इजीली मैनेज होता है. द अदर थिंग इज कि अगर सिचुएशन ऐसी है कि जिसमें जो है कहते हैं हम स्टोन को डायूरेसिस के थ्रू, अगर जो है कहते हैं हम अगर हम डायूरेसिस के थ्रू जो है कहते हैं स्टोन को पास आउट करना चाहते हैं, तो सिंपल जो है कहते हैं हम स्टोन को मतलब पास आउट करने के लिए अपनी दवाओं में शरबत आलू बालू देंगे, बिकॉज दिस इज वेरी पोटेंट आइसोऑस्मेटिक डायूरेटिक. ये दो दवाएं जो है कहते हैं हम रिसर्चेस से बाकायदा प्रूवन और एक्सपेरिमेंटल रिसर्च से जो है कहते हैं जो हमारी दवा है जस्ट 1 मिनट, एक्चुअली जो डिस्प्ले है उसमें थोड़ा सा प्रॉब्लम आ रहा है. तो ये जो हमारी दवाएं हैं इनका तो जो है कहते हैं बहुत अच्छा रिजल्ट है, लेकिन उसकी हर एक चीज की एक लिमिटेशन होती है. तो इसमें जो लिमिटेशन है मीन्स इफ द स्टोन इज ऑब्स्ट्रक्टिव और द स्टोन इज बिग इन साइज, और ये दो स्पेशल ऐसी इंडिकेशंस हैं जिसमें दिस इज इंडिकेशन ऑफ द सर्जरी. मीन्स इफ द स्टोन इज ऑब्स्ट्रक्टिव और द अदर इज स्टोन इज बिग साइज एंड द थर्ड इज स्टोन इज सिम्टोमेटिक. अगर स्टोन सिम्टोमेटिक है, वेरी सिम्टोमेटिक, तो सर्जरी इज इंडिकेटेड, और स्टोन अगर जो है कहते हैं ऑब्स्ट्रक्टिव है तो सर्जरी इज इंडिकेटेड. एंड द नेक्स्ट इज if the stone is big in size. मुझे लग रहा पूरा रुक गया है. Anyway, नेटवर्क इशू पे स्क्रीन शेयरिंग में जरा प्रॉब्लम आ रही है. एनीवे, आई हैव टू कंटिन्यू द लेक्चर.
You continue, sir.
हाँ. So I was discussing about the indications of the surgery. So the commonest surgery in case of renal stone, that is PCNL, percutaneous nephrolithotomy. Percutaneous nephrolithotomy इस सर्जरी में जो है कहते हैं हमें जो जरूरत है एक तो सी आर्म की कि हमारे पास सी आर्म अवेलेबल हो, सबसे इम्पोर्टेंट. दूसरा नेफ्रोस्कोप हो, और समटाइम्स देयर इज अ नीड ऑफ द सिस्टोस्कोप आल्सो. The other thing is the next thing is we have to just give me 1 minute.
Participants, please mute yourself. Audience, please mute yourself. In the meantime, I will request Dr. Manzoor, please. Sir, we have some participants from abroad, from Sri Lanka,
Okay.
who cannot understand, understand Urdu. So please try to translate wherever required. Please translate in English. They cannot understand Urdu. They are not compatible with Urdu. Okay, sir. Go ahead.
Yes. So the PCNL, the percutaneous nephrolithotomy, which needs the C-arm, nephroscope, and cystoscope also. Okay. The next very common surgical treatment is ESWL, any extracorporeal shockwave lithotripsy. The other is URS for ureteric stone. These surgical treatment nowadays are very common to manage the urinary stones. Now we will discuss about the PCNL, means percutaneous nephrolithotomy, which needs the nephroscope, C-arm, and sometimes cystoscope. The first step is we have to catheterize the patient with a Foley's catheter. The next step is we have to put the guide wire through the ureteric through the ureteroscope, and this guide wire is inserted to the, up to the kidney. And the next step, we have to put the patient towards the C-arm to locate the stone, and we have to give the dye to the patient through the ureteroscope, just to confirmation of the site and location of the stone. So later on, we have to locate the stone through the C-arm and put a needle from the skin to the stone. under the guidance of CM. I'll show the complete video. I'll show the complete video of this surgical procedure. इसमें होगा
काम हुआ है क्या इधर अलग उधर दे
Now you are seeing the kidney, urethra, as you know, and there is a stone in the ureter and kidney. First of all, we have to put the scope, and through the scope, we have to put the guide wire from the ureteric meatus up to the pelvic ileal system, and this is the insertion of the dye, and this this is radio opaque dye, and through this dye we can locate the stone by CM. You can see the stone location. The next step, you are seeing the guide wire also, and this is the ureteroscope. Now through the ureteroscope, by shock waves or by laser waves, we are decrystallizing the stone, and finally the step is we should remove. Actually, this is the this is video of URS. Actually, this is not video of PCNL. I'll show the video of PCNL later on. So this procedure was actually URS, in which during this procedure we are decrystallizing the stone through the laser waves or through the shock waves, and finally we are putting the Foley's two-way catheter, and before the Foley's two-way catheter we are putting the DJ stent, double J stent, just to maintain the Now this is the video of percutaneous nephrolithotomy. The same thing. First off, we have to understand the kidney, stone, and ureter and urinary bladder. This is the first step, that we are putting the catheter. The next step, we are putting the guide wire from the urinary bladder to the kidney. Then we are putting the dye, radio opaque dye, just to locate the stone by C-arm. And after location of the stone by C-arm, the next step, through the skin, we are inserting the needle from the skin up to the stone. And through this needle, we are putting the sheath. After the dilatation of the tract, then through this sheath, we are putting the nephroscope, and through the nephroscope, we are putting the laser or shock wave probe to decrystallize the stone, and later on, we are removing the stone through the Dormia basket, or sometimes stone removal forceps. And later on, we are putting the ostomy tube just to drain the urine and the rest crystals through this tube. This is tube, which is known as nephrostomy tube. And this tube is draining all the materials from the kidney and digested. So this was discussion about the PCNL and URS, and the later on we'll discuss about the ESWL, extracorporeal shockwave lithotripsy. In this procedure, we are the first of all we have to confirm the stone site and location through the C-arm, and after the confirmation of the site and location of the stone through the C-arm, we are putting the device which is giving a bombardment of the shock waves to the stone, and the stone is forming through the crystals, so easily this is decrystallized through the shock waves. And now come to the ureteric calculus management, which is carried out through the ureteroscopic management of the ureteral stone, as I have shown to you, and Dormia basketing, ureteric metotomy sometimes, and sometimes if the stone is at PUJ. So during this, for this stone, sometimes we are pushing, we are giving push bang to the kidney and followed by ESWL. And previously we were performing the urolithiasis through the open surgeries, and nowadays these procedures are limited for big size of the stone. For example, for big size of ureteric stone, we are going for open ureterolithotomy. Why the open ureterolithotomy? Because of the big size stone in the ureter, there may be a change in the anatomy of the ureter. The complete anatomy of the ureter has been changed because of the big size stone and long standing stone. So the best procedure is open ureterolithotomy. And open abdominal surgeries for kidney stone, the very famous surgery and very common surgery, which was previously, yani pehle we were doing this procedure, pyelolithotomy, extended pyelolithotomy, if the stone size is very big, and sometimes we are going for nephrolithotomy, and if the stone is situated at the parenchymal tissue, this is near to the parenchymatous tissue, the stone is not situated within the pelvic calyceal system. So this was all about the urolithiasis. Thank you very much, Dr. Mejabin.
Thank you.
All.
Thank you, Manzoor bhai. Hello. Am I audible?
Yes, yes, sir. Yes, yes.
Thank you, Dr. Manzoor Ahmed, for elaborating the etiology of the this urolithiasis, particularly the relation with the summer days. You have explained it nicely. You also explained the etiology of individual stones in detail. Dear audience, our speaker is with us. If you have any query, you can ask our speaker, Dr. Manzoor Ahmed. He is still with us.
अस्सलाम वालेकुम।
हाँ, वालेकुम सलाम।
वालेकुम अस्सलाम।
उस्ताद मोहतरम, एक सलाह इतना था कि DTPA जो है थोड़ा सा सहायक होता है इन्वेस्टिगेशन।
You are not audible, Samiullah.
Hello. Dr. Samiullah, you are not audible.
Hello.
Hello.
Now
yes.
you are audible, sir.
Now you are audible.
अस्सलाम वालेकुम।
वालेकुम अस्सलाम।
हाँ, वालेकुम अस्सलाम।
उस्ताद मोहतरम, सलाम वालेकुम।
वालेकुम अस्सलाम।
हाँ, वालेकुम अस्सलाम।
सर, मैं DTPA एक इन्वेस्टिगेशन होता है किडनी का, उसके लिए मैं ऐड करने के लिए रिक्वेस्ट कर रहा था कि उसको ऐड कर दिया जाए। उससे किडनी का परसेंटेज ऑफ फंक्शनिंग जो है पता चल जाता, कितना % किडनी फंक्शनिंग है, कितना नहीं है। तो जैसे ज्यादा देर तक ऑब्स्ट्रक्शन में जो प्रॉब्लम क्रिएट होती है कि नेफ्रेक्टमी होगी कि क्या होगा, तो इसमें बहुत सहायक होता है। तो DTPA इन्वेस्टिगेशन अगर ऐड हो जाए तो बेहतर होगा। माय हम्बल रिक्वेस्ट।
Usually we are going for DTPA scanning in cases of the obstructive stone. So through the DTPA scanning, we have to know, we come to know about the function of the kidney, and I have discussed about the function of the kidney during the management of the stone urolithiasis. Most of the time, if there is a long standing obstructive stone, there may be a chance of the death of the kidney. That I was saying that the function of the kidney becomes very poor. So just to know the function of the kidney, especially in long standing obstructive stone, we must have to go for DTPA scan.
Okay, sir. Thank you.
Yes.
Thank you, sir. Assalamu alaikum.
Walaikum salam. Thank you, Dr. Samiullah sir. Any other query? Any participant wants to clear any other doubts?
Assalamu alaikum.
Walaikum assalam.
Hi, sir.
Dr. Imran from Delhi. So I want to ask about that each and every patient we should go for surgery, or we can recommend them to start Unani medicine as if they want to delay or they doesn't afford for the surgery.
In first step, we have to give the Unani medicine, and I have discussed about the Unani medicine, which are already proven through the research. That is the Sharbate Buzuri Motadil and Sharbate Alu Balu. These two drugs are proven through the clinical researches. Sharbate Buzuri Motadil is very good drug to avoid the recurrence of the stone formation. First thing. The other thing is the Sharbate Buzuri Motadil is good to treat the non-obstructive stone. If the stone is non-obstructive or the size of the stone is very small, we must have to give our drugs Sharbate Buzuri Motadil, and if the stone is in the tract, means say if the stone is in pelvic axial system and the small size is stone of the stone in ureter but not showing the obstructive pathology, means through the sonography the stone is in ureter but there is a no hydroureter and hydronephrosis, so we must have to use these two drugs, Sharbate Buzuri Motadil and Sharbate Alubalu. So through the diuresis the stone will be passed. But if the stone is obstructive, obstructive means there will be a sign of the hydroureter and hydronephrosis. So we should never try to our drug, because our drug means the our drug could not manage the other thing if this is giving the forceful diuresis. So stone will pass through the ureter and may injure the ureter, may giving the injury to the ureter, and later on if we are trying to pass the ureteric stone forcefully through our drug, so that may give complications. The first injury to the ureter. Injury to the ureter may complicate the ureter and resulting in the stricture formation of the ureter, which is very dangerous condition. The other thing, other complication, bleeding from the ureter. So that bleeding is another complication. These two complications may be there. So the non-obstructive stone and the small size stone, we must have to manage through our Unani drugs. If the stone is obstructive and very much symptomatic, then we have to go for surgery. And for ureteric stone, the URS is very easy surgery, and for kidney stone, the PCNL is also very easy surgery. This is with minimal invasive surgery. So nothing is the problem to the patient. Okay. Any other question?
Thank you, Sarjadaka.
Can I ask?
Yes, please.
Sharbate Buzuri Motadil and Alu Balu should be given at a time, or any one should be chosen? Or
Depends on situation. Depends on situation. If we want to give the treatment of urolithiasis as well as along with the diuresis, then we have to give both the drugs. Otherwise, to avoid the recurrence, the Sharbate Buzuri Motadil is the best drug. And to pass the ureter, if the stone size is very small in size and the non-obstructive stone, so we have to give Sharbate Alu.
okay, but to avoid recurrence, we can continue Sharbate Buzuri Motadil.
Sharbate Buzuri Motadil is the best drug to avoid the recurrence.
How much time, or if in that patient, in some patient with hypertensive drugs, some diuretics are going on. So can we give Buzuri Motadil for the same patients?
We can give the Sharbate Buzuri Motadil along with the anti-hypertensive drugs, and but the Sharbate Alu Balu. For Sharbate Alu Balu, we have to see if the anti-hypertensive drug is combined with diuretic drug, then we have to minus that diuretic drug from antihypertensive treatment and give the Sharbate Alu. And other
Yes.
thing is, you are asking something?
No, please continue, sir. I'll ask later on.
Yeah. Nini, I have completed my lecture. Just I am giving the answer of your questions. So Sharbate Alu, if you are giving the antihypertensive drug along with any diuretic drug, for example, thiazide and all that, then we have to minus that diuretic drug and give the Sharbate Alu.
Okay. And can you please suggest, sir, any medicine to crush the stones, which comes in Unani medicine.
Actually,
Stones, and which stones are crushed and which stones are not crushed with the Unani medicine.
actually, in our system of Unani medicine, the drug is very famous. Purse Hajrul Yahud. Purse Pushta Hajrul Yahud. But this is still not clinically proven. Clinically, अभी तक इस पे किसी ने काम नहीं किया. Experimental work has done to prove the breakage of a stone, but there is no clinical work. We have to go for clinical work to prove the breakage of the stone and all that.
And last question, sir. Urolithiasis, which temperament we will involve to cause the urolithiasis or any stone formation?
No, only for urolithiasis. We are discussing only for urolithiasis. We are otherwise means we have to give the Shagate Buzuri Motadil, and for this thing, the best treatment of the
which temperament, sir, for urolithiasis, causing urolithiasis?
which temperament?
Yes.
Actually, I have not worked out about the temperament. Okay, which temperament is favors the urolithiasis.
Okay, okay, thank you, sir. Jazakallah khair.
But I was discussing about the recurrence of the stone. To avoid the recurrence of the stone, the best treatment is we have to go for stone study, and we have to go for few investigations of the blood investigations of the patient to rule out the calcium status and the citrate status and the oxalate status and rest the uric acid and all that. And later on, we have to calculate the situation and diagnose the recurrence of the stone, means the cause of the stone, which is cause of the stone. Then we have to treat the cause of the stone. This is the best treatment of the to avoid the recurrence of the stone.
Okay, sir. Thank you. Jazakallah khair.
Okay, thank you, Dr. Shabana. I think the doubts are clear now for every participant. Thank you, Dr. Manzoor Ahmed. You have nicely elaborated the various management procedures and etiology as well, and even the presentation of the stones at different stages.
Thank you.
Thank you, sir. We'll, now, let's move ahead on our next topic. Our next topic is thyroidectomy. This talk will be delivered by our colleague Dr. Muhammad Shakil Ansari. This their audience is thyroid dysfunction, whether it is hyper or hypothyroidism, or may it be simple goiter or CA thyroid. The things are very common now. Many people suffer from these thyroid elements. Many of these conditions are managed by the medications only, but equal number of conditions are managed by surgical interventions only. The question arises, when surgery is needed in such conditions, at what stage surgery is needed, and in which condition surgery is needed. This will be explained in detail by our colleague Dr. Muhammad Shakil Ansari, and simultaneously he will tell us about the thyroidectomy also in detail, how the surgery is being taken. Dr. Muhammad Shakil Ansari is BMS and MS from Ajmal Khan Pidya College, Aligarh. He has completed in BMS and MS in 2003 from Aligarh, and then joined Bangalore, then joined Mumbai College, Mumbai Unani Medical College as lecturer. In 2004, he has joined National Institute of Unani Medicine as clinical registrar. And then in 2012, he joined with us in the department of ILMUL JARAHAT, National Institute of Unani Medicine as assistant professor. Since then, he is serving the department and he has taken research in various surgical diseases. Since then, he has attended almost around 50 national and international conferences, seminars. He had almost 50 national and international publications also. He is a brave surgeon of our department who had played a major role in establishing the operation theatre of the department. I will invite Dr. Mohammed Shakil to start his talk on thyroidectomy. Dr. Mohammed Shakil, sir. नहीं, आवाज नहीं आ रही आपकी. No, you are not audible. आपका वालेकुम अस्सलाम. अब आवाज आ रही है.
My presentation is on topic of thyroidectomy. It is a surgical management of the enlargement of the thyroid. Maybe due to
आवाज नहीं आ रही है.
आवाज नहीं आ रही है? How it is coming?
Not audible.
Not audible.
Shakil bhai, use your headphone.
Yeah, Assalamualaikum. Assalamualaikum. Hello. Firdaus?
नहीं, आवाज कम हो रही है आपके हेडफोन की वजह से. बहुत धीमी आवाज आ रही है. हेडफोन लगाने के बाद धीमी हो रही है.
डायरेक्ट कंप्यूटर का यूज कीजिए.
वालेकुम अस्सलाम, लेकिन बहुत कम.
हेडफोन यूज मत कीजिए.
शकील भाई अनम्यूट करिए अपने आप को.
Unmute yourself.
अनम्यूट करिए शकील भाई. ठीक है.
वालेकुम अस्सलाम. हाँ,
आवाज आई?
जी जी अब आ रही है.
आ रही.
स्क्रीन शो कर रहा है?
Yes, yes.
Okay. Assalamualaikum.
वालेकुम अस्सलाम.
My topic is thyroidectomy. As you know, historical background of thyroidectomy is very interesting. The first thyroidectomy was done by Abul Qasim Zohrabi in 952 AD. We think about it. After Abul Qasim Zohrabi, so many surgeons are afraid of this surgery, thyroidectomy. Thereafter, after Zohrabi, the course of this surgery had its crests and troughs. At one point in time, surgeon refused to perform this surgery because of the complications. Later on, surgeons like Bill Roth and Cockers gave this procedure a new lease of life.
धीमी आवाज आ रही है।
हेलो
जी जी,
अब ठीक है?
जी बोलिए बोलिए।
After the surgery performed by Abul Qasim Zohrabi in 952, so many surgeons like Bill Roth and Coker gave this procedure a new lease of life. After which the surgery became popular and underwent numerous modifications. Thyroid surgery has traveled a long path in time from an operation that once was considered dreadful to the present time when techniques are being tried to make the incision as small as possible. Development of thyroid surgery was constant nowadays with a multidisciplinary approach in specialized centers. Theodor Cocker from Switzerland in 1841 and 1970 was the first surgeon to get Nobel Prize in 1901. He did extensive work on thyroid surgeries and designed the present technique. Modern surgeons also called him thyroid surgeon.
टोटल कितनी है? 200.
He first did thyroidectomy in 1876, and by 2012, more than 3,000 thyroidectomies with an eventual mortality rate of 0.18%. So before going to the anatomy of the thyroid, we have to know about a brief idea about the development of thyroid gland. Thyroid gland develop in the floor of pharynx at the point which later forms foramen cecum from columnar cells of the pharyngeal floor as a median downgrowth between first and second pharyngeal pouches. These columnar cells form a tube-like structure that gets canalized to form thyroglossal duct. And this thyroglossal duct descend towards the neck side. After developing in the floor of the mouth, this columnar cell form thyroglossal duct. This duct descend to the neck side. While descending downward, it eventually bifurcates into one on each side to form two lateral lobes of the thyroid gland. The part of the thyroid gland present at its junction of bifurcation forms the isthmus. Once the gland is formed, a remaining portion of the duct obliterates. Part of the duct on the left side forms a pyramidal lobe. Ectopic thyroid tissue can also occur and may be the only thyroid tissue that is present along the line of the duct in the posterior tongue side, which is also called lingual thyroid. Sometimes so many anomalies may be due to agenesis of one lateral lobe of the thyroid gland, or both lobes may be agenous. Only existing one lateral lobe may also present as a toxic or non-toxic solitary nodule. Now we will discuss the anatomy of the thyroid gland. Thyroid means like shield. It is butterfly shaped, brownish red colored, vital endocrine organ situated in the central compartment of the neck. It is located in the anterior triangle of the neck. Size of the thyroid gland is 5 centimeter height, 3 centimeter depth, and 1.5 centimeter width of each lobe. Its total weight is about 20 to 25 grams, a little bit more weight in females. It has got right and left lateral lobes occupying the thyroid space. And thyroid space is very, very critical and very sensitive part of the neck because it lies between trachea and esophagus medially and carotid sheath laterally. Because carotid sheath contains very important structure, for example, common carotid artery, internal jugular vein, and vagus nerve, so many sympathetic chains. And this gland extends from the middle of the thyroid cartilage to the 6th tracheal ring in front side. The isthmus, the part of the thyroid gland, is connecting part between two lateral lobes of the gland. The extent of the isthmus is from second to fourth tracheal link. The size of isthmus is near about 1.5 into 1.5 centimeter. Though isthmus may be absent in 10% of the individual also. Thyroid gland extend from cervical 5 to the T1 vertebral level from behind side. Pyramidal lobe is the third lobe. It is an extension of gland upwards on the surface of the cricoid cartilage toward the left side, which often extend above to the hyoid bone with the help of a fibromuscular strand from the junction of isthmus and left lateral lobe. It is present, or we can say pyramidal lobe present only in 33% of individuals. This fibromuscular strand is also called levator glanduli thyroidi, and it provides a strong support to the thyroid gland. The gland is invested by, it is covered by on all sides by the pretracheal fascia. The thyroid gland is also supported by a strong condensed vascular connective tissue between lateral lobe of the gland and cricoid cartilage on each side. This strong condensed vascular connective tissue is also called Berry's ligament. This Berry's ligament is very important when we will do the surgery of the thyroid, or we can say dissection of the thyroid has an important part to dissect the Berry's ligament also. So before going to the further, we have to talk about the covering of the thyroid gland, or we can say capsule of the thyroid gland. Thyroid gland has two capsules, true thyroid capsule and false capsule. The true thyroid capsule is peripheral condensed connective below or deep to it. The true capsule is covered by a further capsule, which is false capsule. This false capsule is derived from the pretracheal layer of deep cervical fascia. False capsule is nothing else, but it is pretracheal layer of the deep cervical fascia. This false capsule is thin in the front side of the gland, while it is thick behind and also very much thick in the form of Berry's ligament above and behind of the gland. The surgical plane, or the plane for the removal of the gland, it is avascular plane. It is located between the two capsules. I mean between true and false capsule. We will do avascular surgery, or plane of the vascular surgery lie between the true capsule and false capsule. Some important anatomical structures are there in relation to the thyroid gland. We have to know very detailed knowledge about this structure before performing any thyroidectomy surgery. Each lateral lobe of the thyroid gland has got lateral, medial, and posterior lateral surfaces, anterior and posterior borders, and apex and apex. Lateral surface is covered by, lateral surface of thyroid gland is covered by sternocleidomastoid muscle, sternohyoid muscle, omohyoid muscle, and sternothyroid muscle in deeper area, in deeper plane. Medial surface of thyroid gland is related to trachea, esophagus, cricothyroid muscle, inferior constrictor muscle of the larynx, external laryngeal nerve, and recurrent laryngeal nerve, as we can see in this figure. Anterior jugular vein, it is not related to the any supply to the thyroid gland, but it is the veins run on the anterior surface in front of the muscles. Or when we start the dissection, first of all, just after cutting the platysma, we will see this vein. Usually, in few cases, it may be absent also. We have to know a little bit idea of the muscles in the anterior aspect of the neck before performing thyroidectomy. So neck muscles are divided into two groups, suprahyoid muscles and infrahyoid muscles. Suprahyoid, it means above the hyoid bone. Infrahyoid, below the hyoid bone. Or all these muscles are directly or indirectly attached to the hyoid bone. Suprahyoid muscles are four: stylohyoid, geniohyoid, mylohyoid, digastric. These four muscles are not involved or not dissected in thyroidectomy surgery. So we will focus on the infrahypoid muscles. These muscles are dealt with us during the surgery of thyroid. The infrahypoid muscles are 4 muscles. Step muscles, these are also called step muscles. Sternohyoid in the front side or superficial plane. Omohyoid also just alongside the sternohyoid or lateral to the sternohyoid, omohyoid. These 2 muscles are superficial and 2 muscles are in the deeper plane. These are sternothyroid and thyrohyoid. These 2 muscles are in deeper plane. We can see this is the condition of anterior view of the thyroid gland. Superiorly, thyroid bone, after that thyroid cartilage, and just after thyroid, just beneath the thyroid cartilage, we are seeing 3 main lobes of the thyroid gland, 2 lateral lobes and 1 pyramidal lobe. And arterial as well as venous drainage, it is clearly mentioned everything. Anatomy of this structure is very important to do the thyroidectomy. Now we will discuss in detail about the arterial supply of the thyroid gland. 2 main arteries, these are superior thyroid artery and inferior thyroid artery. Third one is thyroid ILMUL artery, which occurs in 3 to 10% of cases. And fourth, accessory thyroid arteries, group of arteries from the tracheal and esophageal side. They also supply from the posterior side of the thyroid gland. So superior thyroid artery is a branch of external carotid artery on both sides, right and left. This artery enters the gland near the superior pole as a larger anterior superficial branch and a smaller posterior branch. Or we can say superior thyroid artery divided into 2 parts, anterior branch and posterior branch. And this superior thyroid artery enters the gland along with it is accompanied by the external laryngeal nerve. Path of the superior thyroid artery follow the external laryngeal nerve also. This external laryngeal nerve is most commonly damaged during the surgery if proper care is not taken. This external laryngeal nerve, it is a branch of superior laryngeal nerve, and this superior laryngeal nerve is a branch of vagus nerve. This external laryngeal nerve supplies the cricothyroid muscle of the larynx, and this cricothyroid is the tensor of the vocal cord. So if we damage the external laryngeal nerve, then pitch of the voice will be disturbed, or patient voice will be disturbed. So we have to safeguard external laryngeal nerve during the dissection of or during the ligation of superior thyroid. Second artery is inferior thyroid artery. Inferior thyroid artery is a branch of thyrocervical trunk of the subclavian artery that runs upwards medially, then downwards behind the carotid sheath and middle cervical superior ganglion and in front of the vertebral vessels. And this inferior thyroid artery, after passing to the near to the thyroid gland, it divided into 4 to 5 terminal branches. These 5 terminal branches pierce the pretracheal fascia separately to supply and enter the lower pole of the thyroid. Its ascending branch also supplies the parathyroid gland. So we can say inferior thyroid artery supplies the lower part of the thyroid gland as well as all the 4 parathyroid gland also. The inferior thyroid artery supplies the thyroid gland lower part as well as all the 4 parathyroid glands. One more artery, that is thyroid ILMUL artery. This is the lowest thyroid artery arising from the arch of the aorta or brachiocephalic artery and enters the gland and isthmus from lower side. Fourth group of arteries which supply the thyroid gland are accessory thyroid arteries. These group of arteries arise from the tracheal and esophageal arteries and also supply the thyroid gland. Now we will discuss about the drainage, venous drainage of the thyroid gland. There are 3 common veins to drain the thyroid gland. Number 1, superior thyroid vein from upper pole. This vein accompanying the artery. सुपीरियर थायराइड आर्टरी को ये फॉलो करता है. आफ्टर दैट it will drain into the internal jugular vein. So we can say superior thyroid artery as well as superior thyroid vein. These both make upper vascular trunk of the thyroid gland. Middle thyroid vein, second one, it may be absent in 33% of cases. Middle thyroid vein is a short, wide, thin-walled vein that begins from the mid-lateral aspect of the lateral lobe, runs a short distance in front or behind the carotid artery. Very important structure. Carotid artery के आगे या पीछे it will travel and immediately enters into the internal jugular vein. Or we can say superior thyroid vein, middle thyroid vein, both vein drain to the internal jugular vein. And secure ligation of the vein is very important, because if there is any damage in the middle thyroid vein, because this vein is directly connected to the internal jugular vein, and any trauma to the middle thyroid vein may go to the internal jugular vein trauma also. So secure ligation of the vein is needed, and if it tears, it may extend into the internal jugular vein, causing torrential hemorrhage. As it is the one, this vein is also one structure that holds the gland posteriorly, or middle thyroid vein provide a little bit support to the thyroid gland. So until we dissect this middle thyroid vein, we cannot do any procedure further. So it should be ligated first to mobilize the gland. We cannot do mobilization of the thyroid gland without dissecting and ligation of the middle thyroid vein. There is no any accompanying artery to the middle thyroid vein, or we can say there is no middle thyroid artery. Third vein is inferior thyroid vein. It begins at the lower pole of the isthmus and form a plexus in front of the trachea, later joining the respective brachiocephalic vein of right side and left side. These veins are not accompanied by inferior thyroid artery, because the course of the inferior thyroid artery is little bit lateral side, and this is in the midline. Occasionally, sometimes both the inferior thyroid veins form a common trunk, so that it may be called thyroid IMA vein, which joins the left brachiocephalic vein. Now we will discuss the relation of some important structures. Three structures are very important. These three structures to be saved, to be protected during thyroidectomy surgery. If we do damage to these three structures, then so many complications may occur. Important one is external laryngeal nerve. We have to know about the origin of this nerve. This is a branch of the superior laryngeal nerve. And superior laryngeal nerve, it is a branch of vagus. Vagus nerve gives a superior laryngeal nerve branch from its inferior ganglion at the level of hyoid bone in the jugular foramina. There are two ganglion in the jugular foramina: superior ganglion, inferior ganglion, superior vagal ganglion, inferior vagal ganglion. So from inferior vagal ganglion, two nerves are one branch and one main nerve. Main vagus nerve emerge from the inferior vagal ganglion, and also inferior vagal ganglion gives superior laryngeal nerve. So these two travel towards the downside in the neck. And this superior laryngeal nerve further divided into two parts: internal laryngeal nerve and external laryngeal nerve. Internal laryngeal nerve supply the larynx above the cord, sensory supply as well as sympathetic supply above the parasympathetic supply above the vocal cords. But external laryngeal nerve, it supplies the cricothyroid muscle of the larynx. This muscle do the tension, or produce the tension in the vocal cords, and it is very important for the proper pitch of the voice. It may get injured while ligating the superior pedicule when we are doing the dissection of the superior thyroid artery and superior thyroid vein. Then at the same time, if we don't save the external laryngeal nerve, it may get damaged, and this may cause defective pitch of voice. So the upper pedicle of the thyroid should be ligated close to the gland, but it should be after identification and dissection of the nerve. We have to save first nerve, then we will do the ligation of the superior thyroid artery as well as vein. Second important nerve which to be saved during dissection of the lower pole of the thyroid gland is recurrent laryngeal nerve. This is a branch of again vagus nerve, and vagus nerve after descending into neck, it will hooks around the ligament of arteriosum on the left with near the arch of the aorta in the left side, and right side pe this will hook around the right cervical artery on the right side. After that, it will again take the same path, or it will come back to the same side in the neck towards the larynx, so that it is called recurrent laryngeal nerve. After passing to the downside, it will again go to the upper side, so that it is called the recurrent laryngeal nerve. It runs in the tracheoesophageal groove near the posterior medial surface of the thyroid gland. This nerve lies in between branches of the inferior thyroid artery. Before passing to the larynx, it will go sometimes anterior to the inferior thyroid artery, sometimes posterior to the thyroid artery, sometimes in between the branches of inferior thyroid artery. So we have to save this nerve very securely before doing dissection of the inferior thyroid artery as well as its branches. The next most important structure to be saved during surgery of the thyroid is parathyroid gland. As we know, there are 4 parathyroid glands, 2 on each side. Or sometimes it is embedded in thyroid gland also. Removal of all 4 glands in thyroidectomy may lead to the severe hypoparathyroidism and hypocalcemia. If we save the parathyroid gland, then we will avoid these 2 complications. So we have to try to save all 4 parathyroid glands during dissection of the thyroid gland. Thyroidectomy is the surgical removal of all part of the thyroid gland or a single part or partial removal of thyroid gland. Thyroidectomy is the surgery of precision, patience, and perfection, because so many important structures are lying surrounding the thyroid gland. So we have to be very much patient, and perfection should be there during this section also. Indication of thyroidectomy, as we know, toxic multinodal goiter, toxic solitary nodule, malignant of goiter, presence of pressure symptom due to huge size of the thyroid gland. If there are presence of pressure symptoms, then we have to plan thyroidectomy. Large goiter which not respond to drugs and relapse is likely. Complication during drug therapy, relapse after previous drug therapy, exophthalmos, and for the purpose of postnasis. Preoperative preparation is very important before doing thyroidectomy. First of all, we have to do blood grouping, cross matching, because there may be chances of requirement of blood. So it should be ready. We have to do indirect laryngoscopy, because in 3% of patients, there is called paralysis without any symptomatic presentation. We have to rule out this thing. Serum calcium estimation, T3, T4, TSH. We have to do this thing to rule out the euthyroid condition before doing thyroidectomy. And we have to get endocrinologist opinion also. We have to do ECG and cardiac fitness, especially in toxic goiter. Radioisotope iodine scan and FNAC is also very important investigation. Thyrotoxic patients are rendered euthyroid by carbimazole 10 to 15 mg 8 hourly before doing any surgery. When patients become euthyroid in about 4 weeks, they are maintained on 5 to 10 milligram of the carbimazole 8 hourly. Propanol is also very good effective beta blocker, 80 milligram 6 hourly, 4 to 7 days before operation. Symptoms and signs are usually controlled within 24 hours, but it should be continued 8 to 10 days post-operative. We have to also give Vigol's iodine solution 2 weeks to reduce the vascularity of the gland. Informed consent should be taken before doing thyroidectomy. Important principles to be adopted in case of thyroidectomy. In the surgery of thyroidectomy, very important principles are there. Number one is to attain absolute hemostasis. So for imported dissection or deeper dissection, we have to use bipolar cautery. We have to use monopolar cautery only for the one step, that is superficial step, that is the elevation of the flex. We have to use monopolar cautery. But dissection near the upper pole and lower pole or thyroid tissue will be dissected with the help of bipolar cautery. We have to arrest any bleeding point with the help of bipolar cautery. Minimize the use of monopolar cautery in main dissection, because it may cause lateral heat damage, and this damage may cause recurrent laryngeal nerve and parathyroid blood supply damage. It may cause damage to the recurrent laryngeal nerve or parathyroid blood supply may damage due to the use of monopolar cautery using in the deep dissection. So prevention of injury to the recurrent laryngeal nerve and external laryngeal nerve is also very important. Preservation of the parathyroid gland is very important to avoid any parathyroid hypoparathyroidism after operation. Osmosis should be important. Meticulous technique should be adopted. Recurrent laryngeal nerve and external laryngeal nerve should be identified during this section. All vessels should be ligated individually. Mass ligation is not suitable because it may cause damage to the surrounding important structure. One should avoid mass ligation. It was commonly practiced, but it is not a good thing. To avoid complication, we have to avoid mass ligation. Middle thyroid vein, superior thyroid artery. First of all, we have to do middle thyroid vein dissection and ligation. After the superior thyroid artery. After that, inferior thyroid artery and vessel and vein. So many types of thyroidectomy are there. Important are hemithyroidectomy. Hemi means half of the thyroid gland will be removed. Removal of one lateral lobe with the entire stomach. Stomach should be removed entirely. It is done in benign disease involving only one lobe, like solitary thyroid nodule, or toxic or non-toxic. Solitary thyroid nodule is there, then we have to do hemithyroidectomy involving only one lobe. Second type of the thyroidectomy is subtotal thyroidectomy. It is the removal of most of both lateral lobes, including the stomach, except around 8 grams of the tissue, or tissue equal to the pulp of little finger is left in the lower part of the thyroid gland. It is done in toxic thyroid and often in non-toxic multinodal goiter. It will reduce the incidence of hypoparathyroidism and injury to the recurrent laryngeal nerve. So subtotal thyroidectomy will be done in cases of toxic thyroid or often non-toxic multinodal goiter. Second is total thyroidectomy. In total thyroidectomy, entire gland is removed without retaining any tissue of the thyroid. It is the present procedure of choice in most thyroid disease except benign disease. In benign disease, we will do subtotal or partial, but in case of carcinomatous diseases, we have to do total thyroidectomy. One scientist, Hartley Dunley operation, they have developed this thing. It is the removal of one entire lateral lobe, isthmus, and partial removal of the opposite lateral lobe. It is used in non-toxic multinodular goiter. And one procedure is isthmectomy. Suppose we cannot do surgery due to the advanced carcinoma, or sometimes in case of radial thyroiditis, this radial thyroiditis create the constricting band, fibrosing constricting band. So to treat this radial thyroiditis, we have to do the isthmectomy so that we can cure severe stridor due to tracheal narrowing. This radial thyroiditis produce fibrosing band which cause tracheal narrowing and produce and symptomatic presentation severe stridor. So to prevent the severe stridor, we have to do isthmectomy, or isthmus will be removed. Anesthesia. General anesthesia with a curved enterotracheal tube is the most suitable procedure before proceeding the thyroidectomy. And position of the patient is usually semi-fowler position. In the semi-fowler position, neck is extended. We have to do extension of the neck by placing sandbag or folded sheet underneath the shoulder. And to support the head, we have to use ring under the occiput. Both arms are kept beside the patient's body and hands are tucked under the patient's buttock. Cotton pads are placed under the elbow to prevent ulnar nerve compression. So this is the typical position. Head end of the table is elevated to 15 degrees to improve the venous return, so as the reduced venous congestion in the neck, and so oozing will be reduced. So this is also, we can say, reverse transrenal position or focus position. This increases the risk of ear embolism also due to negative pressure created in the neck vein. So that ligation of vein is very important. Vein should be ligated securely and then only cut. Anesthetist to be on the head side and away from the field of surgery, with sides kept free for the surgeon, assistant, and scrub nurse. So before starting the surgery, we have to do scrubbing or cleaning of the area. Neck, face, chest, up to the nipple is done with the help of iodine, betadine. Draping is done. Draping is done on all sides. Double towel is used under the head, and one of the towels, outer one, is covered over the outer part of the endotracheal tube. Surgeon usually stand on the right side, assistant on the left side, scrub nurse on the right side at the foot end of the patient. Energy sources like cautery, both unipolar as well as bipolar, should be kept ready. And suction apparatus with a fine suction tip is also required. Incision. Horizontal incision is placed 2 finger breadth above the sternal notch, extending from the lateral border or posterior border of the one sternocleidomastoid to the opposite side of the sternocleidomastoid muscle. So incision will be 2 finger above the sternal notch and from one sternocleidomastoid muscle to the another side sternocleidomastoid muscle. Incision is marked by placing stretched thread or silk over the skin. It can be marked using marking ink also. Skin is inside using number 15 blade or cautery may also be used. Platysma is identified and incised slightly at a higher level than skin incision to prevent it from getting adherent to the scar at a later period. Platysma कहीं scar पे attach ना हो जाए, उसको avoid करने के लिए platysma को थोड़ा higher level पे incise करते हैं. Next important step in the thyroidectomy surgery is the raising of the flaps, upper flap and lower flap, because we have given the transverse incision, then 2 flaps are created, upper flap and lower flap. Upper flap, subplatysmal flap, is raised up to the thyroid cartilage. Lower flap, it is raised up to the sternoclavicular joint or supraesternal notch. Raising of the flap is done either using cautery or number 15 blade, but usually we have to use monopolar cautery. All bleeders are fulgurated properly. Care should be taken not to injure anterior jugular vein, because anterior jugular vein is just above the muscles. So we have to avoid injury to the anterior jugular vein because negative pressure is there in the veins. So it may cause air embolism. So we have to avoid any inadvertent injury to the anterior jugular vein in the starting. Care should be taken not to injure anterior jugular vein running on either side of the midline. There may be the chances of air embolism if it is injured. So we have to avoid injury to the anterior jugular vein. In the lower part of the wound, near the lower flap, both anterior jugular vein communicate through a communicating vein, which, if injured, may cause bleeding and air embolism. In such situation, anterior jugular veins distal to the communicating vein level should be ligated to prevent air embolism. Later, we will do ligation of proximally, ligation of the vein proximally. Next step after raising the upper flap and lower flap, we will do retraction of the flap, because we have to do surgery in the deeper plane. And these 2 flaps do not interfere in our surgical steps. So we have to do retraction of the flap. For retraction of the flap, we have to use self-retaining Johnson thyroid retractor or we can use silk skin suture to upper and lower flap. Instead of Jones retractor, Hamburg, Brennan, Mahorener self-retractor can also be used. ये दो सेल्फ रिटर्निंग रिट्रैक्टर से उनको यूज कर सकते हैं. अदरवाइज वी कैन यूज सिल्क सुचर आल्सो. जो मेन डिस्ट्रक्शन है, इसके बाद जो हमने फ्लैप को अपर फ्लैप एंड लोअर फ्लैप आफ्टर एलिवेटिंग these two flaps and retracting these two flaps, we have to go to the further dissection. And next dissection is the deep fascia is inside. First of all, in the midline, we have to do deep fascia incision. Step after giving the facial incision, step muscles are retracted. Sternohyoid, omohyoid, sternocleidomastoid, all these muscles are retracted to the lateral side. Sternothyroid is in the deeper plane, it should also be retracted. Midline plane is bloodless. The incision is done at the plane, and the plane is opened using cautery usually, or 50 number blade, or fine scissor can also be used. But usually we use monopolar cord. Now we are going to the deeper side. Now we will use only bipolar cord. Step muscles are retracted laterally using a deep retractor. If the gland is large and if there is difficulty in mobilizing the gland, then step muscle can be cut between two focus clamps at their upper part. Why? Because step muscles gets nerve supply from the lower side. So we can cut the step muscle in the upper part. Thyroid fossa, very important place. It is lie in the deep and lateral part of the lateral lobe of the thyroid gland. Thyroid fossa, it lies lateral and deep to the lateral lobe of the thyroid gland. It should be dissected using blunt or sharp dissection. So we have to do dissection in the thyroid fossa. Lateral lobe of the thyroid is held with the help of back of forceps to retract a little bit medially. When we will do the medial retraction, a short, stout middle thyroid vein is identified, and it should be ligated securely. Double ligation is very important with the help of 3-0 Vicryl or SIP. Until we do the dissection of this middle thyroid vein, we cannot mobilize the gland safely to the medial side, or we cannot visualize the upper pole as well as lower pole. The first important step is the dissection of the middle thyroid vein. Blind dissection near the middle thyroid vein may tear or avulse it. यानी middle thyroid vein may be avulsed from the internal jugular vein. और अगर ऐसा हो गया, then there will be torrential hemorrhage. पूरा खून ही खून हो जाएगा, क्योंकि venous bleeding start हो जाएगी. So we have to avoid any damage to the middle thyroid vein, or any blind dissection should not be done. We have to first see, first visualize, and then do the dissection near the middle thyroid vein. After doing the dissection in the middle thyroid vein, we will do, gland is now retracted downwards to expose the superior pole, downward and laterally. थोड़ा सा हम रिट्रैक्ट करेंगे मिडल ग्लैंड को, तो हमने उसे होल्ड कर रखा है विद द हेल्प ऑफ फोर्सेप, तो उसको थोड़ा सा डाउनवर्ड एंड लेटरली जो है रिट्रैक्ट करेंगे. देन सुपीरियर पोल विल बी विजुअलाइज्ड क्लियरली. देन वी विल डू, आफ्टर विजुअलाइजेशन we will do the dissection at the area of superior pole, or we will dissect it with the help of sharp dissection or period dissection. The superior thyroid artery and vein should be visualized. This space in front of the cricothyroid muscle is called cricothyroid space of Reeves, यानी cricothyroid muscles के आगे का हिस्सा और ग्लैंड के पीछे का हिस्सा, इन दोनों के बीच में जो स्पेस है, तो this space is cricothyroid space of Reeves. And this space have important structure. We have discussed previously. That is the external laryngeal nerve. External nerve, which is just proximal to the superior pole. Superior pole से थोड़ा पहले वो cricothyroid muscle को supply कर देती है, लेकिन upper pole तक आ रही है. So we have to be very careful to avoid any damage to the external laryngeal nerve. The superior pole deviates towards the cricothyroid muscle. The cricothyroid muscle is tensor of the vocal cord, which maintain the pitch of the voice. We have discussed already. This nerve should not be injured. So artery and vein, we can say superior thyroid artery and superior thyroid vein. It should be ligated individually, no mass ligation. And also after saving the recurrent laryngeal, after seeing and visualizing, and safety of the recurrent laryngeal, external laryngeal is very important before doing ligation of the upper port. Artery should have 3-0 between, say we have to do ligation of the artery as well as vein. Slipping of ligature post-operatively can cause life-threatening hemorrhage. So we have to be very careful at this step of the ligation of the superior thyroid artery as well as vein. It is advisable to identify external laryngeal nerve with careful dissection to safeguard it to prevent developing an altered pitch. Inferior pole of the thyroid is exposed, and after completing the surgery in the upper pole, we have to come now to the lower pole. An inferior pole of the thyroid exposed and inferior thyroid vein are ligated adjacent to the gland. Often, thyroid ILMUL venous plexus may be present in front of the trachea in midline. This should be ligated properly because this inferior thyroid vein lie midline, in the midline. So it should be ligated. After that, we will do the dissection. Both blunt dissection and sharp dissection using peanut, fine scissor, and mosquito forceps with gentle pressure over the gland medially will expose the recurrent laryngeal nerve near the lower pole and parathyroid gland also. So recurrent laryngeal nerve passes behind the inferior thyroid artery in tracheo-esophageal groove. Inferior thyroid artery arises from the thyrocervical trunk of the subclavian artery, running upward, then downward, and then medially under the carotid artery, either front side or anteriorly to the carotid artery, to reach the gland in front of the recurrent laryngeal nerve. Usually recurrent laryngeal nerve lie in between the branches of the inferior thyroid artery. So we have to identify, we have to visualize these branches of the inferior thyroid artery to safeguard the recurrent laryngeal nerve damage. To control any bleeder in this region, bipolar cautery should be used, never unipolar. The branches of the inferior thyroid artery, while entering the gland, should be ligated with the help of 3-0 Becquerel or 6. Ligating the inferior thyroid artery or its branches close to the gland avoid injury to the artery of the parathyroid from the inferior thyroid artery, because parathyroid की जो supply है वो भी inferior thyroid artery से है. तो inferior thyroid artery की जो branches parathyroid को जा रही हैं उनको डिसेक्ट नहीं करना है, हमको उसको सेव रखना है. सिर्फ जो inferior thyroid artery की branches thyroid gland को सप्लाई कर रही हैं, those branches will be ligated and dissected. Previously, olden days में क्या होता था, classical method of ligating the inferior thyroid artery away from the gland just after crossing behind the carotid artery is not practiced now, because अगर हमने main trunk of the inferior thyroid artery को ligate कर दिया, then supply of the parathyroid will also be disrupted. So we have to save the supply of parathyroid artery. One more important structure is Berry's ligament, which is adherent to the thyroid, is cut with care to mobilize the gland properly medially. अच्छा, Berry's ligament के पास ही recurrent laryngeal पास करती है, उसी के पास से towards the upper side to go to laryngeal supply. Laryngeal supply करने से पहले ये thyroid gland का जो Berry's ligament है उसके पास से गुजरती है. So we have to be careful to save again the recurrent laryngeal nerve. So it is lying very close to a Berry's ligament. It should be identified and saved. Berry's ligament को कट करने से पहले recurrent laryngeal nerve को हमको again save करना है. तो recurrent laryngeal nerve को दो जगह सेव करना है. First lower pole पे, then upper pole की साइड पे posteriorly Berry's ligament के पास. Parathyroid gland vary in their position. कभी ये ऊपर होती है, कभी थोड़ा नीचे होती है, कभी neck के region में होती है, कभी-कभी chest में भी चली जाती है. तो parathyroid gland vary in their position on the surface of the gland, but can be easily identified. We can easily identify parathyroid gland with their different color. इसका जो कलर होता है golden yellow color. So we can easily identify it as parathyroid gland. और parathyroid gland बहुत छोटी सी होती है, मसूर के दाने के बराबर, lentil seed के बराबर. Gland should be dissected of the thyroid with their blood supply. Gland को भी बचाना है, parathyroid gland को इसकी blood supply को भी बचाना है, जो कि आ रही है inferior thyroid artery से. So gland should be dissected of the thyroid with their blood supply. Ideally, it is required all 4 parathyroid should be preserved. अगर नहीं बच पाई एक आध तभी काम चलता है. और अगर by mistake we have dissected all the 4 parathyroid, then we have to implant these dissected parathyroid to the sternocleidomastoid muscle. So ideal way क्या है? All the 4 parathyroid should be preserved, though 1/3 of the one gland is sufficient to maintain the function of calcium metabolism by parathyroid gland. But ideal, we have to save all 4. If we have them dissected by mistake, then we have to do implantation of this dissected parathyroid to the sternocleidomastoid muscle में. इसको हमें auto transplant करना पड़ेगा. Unnecessary handling of the parathyroid should be avoided because it may cause ischemia or blood supply will be hampered. Again, function of the parathyroid will be disturbed post-operatively. Complication may be there. The handling of the gland makes it congested. Viability of the parathyroid can be checked by carefully incising it using fine scalpel. If we are in suspicion, either it is live or it is dead or supply is hampered, then we have to do careful incision. Doubtful gland should be sliced adequately and transplanted into same side sternocleidomastoid muscle. If it is dissected, if it is removed from or blood supply has cut of the parathyroid, then we have to implant this parathyroid into the sternocleidomastoid muscle of the same side. Inferior pole vessels are individually ligated. Inferior pole पे जो हमारी आर्टरी थी, opposite lateral lobe is also dissected similarly. अब एक साइड का हमने लोब डिसेक्ट कर लिया, upper pole, middle thyroid vein, upper pole, lower pole. Same process we have to opt in the second lobe in case of total thyroidectomy. Thyroid is dissected after completing the both side dissection of the upper middle thyroid vein or middle side dissection, upper pole dissection, after that lower pole dissection. Then we will do removal of the thyroid from the anterior surface of the trachea because it is adhered to the trachea or it is also adhered to the cricoid पे यानी जो बेरिज लिगामेंट है, it is the fibrous ligament attaching the thyroid gland, posterior side of the thyroid gland to the cricoid. So we have to do dissection of these two things. The thyroid is dissected from the anterior surface of the trachea using cautery or fine scissors. If part of the gland is retained in the trachea or esophageal groove, in case of subtotal thyroidectomy, हमने अगर थोड़ा सा part subtotal thyroidectomy, we have to remove partial or we have to remove near about total little part near about to the pulp of the finger or 8 to 10 gram of the gland is retained there. So if it is retained in the tracheo-esophageal groove, it should be oversewn to avoid any oozing. So surface of the dissected surface of the gland should be oversewn with the help of 3-0 Vickrell suture. Fine clamps are placed in series on the thyroid capsule. The gland is transected using a number 15 blade to do the subtotal thyroidectomy. The retained gland is undersewn using 3-0 Vickrell suture, continuous locking suture to stop the oozing from the dissected thyroid gland. Anterior part of this thyroid gland is sutured to the trachea. In hemithyroidectomy, one lateral lobe and entire isthmus is removed. The junction of the isthmus and the opposite lateral lobe is clamped using hemostat or coccus clamp and the gland is cut. After that, again we will do clamped retained gland is underrun or overseen with the help of 3-0 Vickrell to stop as much as possible the oozing from the dissected gland. Proper hemostat is done using bipolar cautery. Pedicles are again inspected for their security. ऐसा तो नहीं कहीं से oozing start हो गई है, जो हमने dissection किया था upper pedicle, lower pedicle पे, उनको we have to do again inspection to stop any post-operative complication in the form of hematoma formation. After completing the dissection, we will do the closure. So before doing the closure, we have to remove sandbag because sandbag is produced to produce extension of the neck. So we will do relaxation or we will do the removal of the sandbag. Again, hemostasis again confirmed because sometimes due to stretching in the condition of extension, bleeding vessels, small minute bleeding vessels are stopped. No bleeding is there. But after removing or after gaining the original condition from retraction, from traction, stretch condition, then again small oozing will start. So we have, after removing the sandbag, we have to again check hemostasis there or smoothing is started. Often stretched neck prevents bleeding from small vein, but once the sandbag is removed, they may bleed. This should be controlled again with the help of bipolar cord or ligation. Traditional suction drain is placed, which is brought out through a separate stem incision. The drain should pass under the staph muscles to reach the thyroid fossa. We have to put the drain in the thyroid fossa. If proper hemostasis achieved, हमें लगता है एकदम dry है, कोई oozing नहीं है, then a drain can be avoided. If we are in suspicion of post-operative oozing, then we have to place the drain. Staph muscles after that approximated using interrupted 3-0 विक्रियल suture. दो चार suture मार देते हैं ताकि जो muscles हमने detect किए हैं वो midline में आ जाए. Platysma suture using 3-0 विक्रियल interrupted suture. Subcuticular absorbable 3-0 monocular suture is also used for skin closure. Dressing with pressure using Dynaplast is the usual practice. Though nowadays placing soft light dressing or without any dressing may also be practiced. The prevention of post-operative bleeding depend on the good intraoperative hemostasis. During procedure जितना हमने अच्छे से hemostasis achieve किया है, it will give benefit during the post-operative period. The prevention of post-operative bleeding depend on the intraoperative technique. How much you are precise in doing the dissection of the upper pole, middle pole, and lower part, middle part of the gland or lower pole. Hemostasis in thyroid surgery is achieved by means of clamp and tie, diathermy unipolar initially in the upper part, and deeper dissection में bipolar. Ultrasonic coagulating dissection methods such as harmonic scalpel may also be helpful for doing the proper hemostasis achieved. Or electrothermal bipolar vessel sealing system, which is also used nowadays. Sometimes due to the, if we are doing the thyroidectomy in case of CA thyroid, then we have to do lymph node dissection of the neck also. Usually we have to do pretracheal and tracheoesophageal lymph node are removed routinely in all thyroid surgery because we are doing the dissection in the same area. So in the pretracheal area and tracheoesophageal groove में जितने भी lymph node हैं उनको we have to remove. अगर facility frozen section biopsy की facility available है, then we have to do deep cervical lymph node dissection and do the frozen section biopsy to rule out any further extension of the CA to the surrounding area. If it is involved, if the deep cervical node is involved, then we have to do modified radical NAND dissection with the help with the preservation of the internal jugular vein, accessory nerve, and external clitoral muscle. इनको बचाते हुए we have to do modified radical neck dissection to remove the secondary जो lymph node थे. Primary lymph node तो esophagus trachea के आसपास के हैं जिनको हम usually without any further extension of the incision remove कर सकते हैं और routinely it should be done. लेकिन अगर distant जो थोड़ा सा दूर का हिस्सा है और we can say जो deep cervical lymph node है उसको we have to do first frozen section biopsy. If it is involved, then we have to do this thing. For doing the deep cervical node dissection, we have to do same thyroid incision extended laterally and above towards the mastoid process. To do additional lymph node dissection, for bilateral neck dissection, the incision should be extended on both sides, and with the help of extended incision, we can do dissection or removal of the lateral side deep cervical lymph node. Sympathetic chain and hypoglossal nerve should be preserved. It should be safe. In medullary carcinoma of thyroid, central node dissection, often modified neck dissection with the dissection of the upper mediastinal node and thymus is also sometimes required. Meticulous dissection is needed to preserve recurrent laryngeal nerve and parathyroid. In any malignancy with clinically significant palpable nodes confirmed by FNAC, modified neck dissection is done along with the total thyroidectomy. तो जो neck dissection है इसको जब भी करते हैं जब हम thyroidectomy कर रहे हैं for the purpose of CA thyroid. Post-operative care is very important. Patient is kept in post-operative room with head and tilted 30 degrees upward. Patient should be observed for bleeding, formation of hematoma, stridor, ऐसा तो नहीं आवाज उसकी कुछ जो है साफ नहीं आ रही है, घबराहट है. ड्रॉप इन ऑक्सीजन सैचुरेशन, टैकीकार्डिया, टैकीपनिया, these all points should be observed minutely. Tension hematoma under staph muscle is very dangerous and should be relieved if we अगर हमें लगता है पोस्ट ऑपरेटिव पीरियड में कोई स्वेलिंग हो रही है, बढ़ रही है और मरीज को ये सारी चीजें सिम्टम्स अपीयर हो रहे हैं, then we have to remove this tension hematoma in the ward itself. Relieve by removing sutures from the skin and staph muscles. It is life-saving procedure with immediate intervention, otherwise it can be life-threatening. OT में शिफ्ट करने से पहले बेड साइड पे we have to remove the suture of the skin as well as staph muscle so that this hematoma may not compress important structure of this area. अगर ये चीजें नहीं हुई है, hematoma develop नहीं हुआ है, then drain is removed after 24 to 48 hours depending on the quality of collection in the drain. Tetany may be observed sometimes in few cases in 3 to 4 days due to the hypocalcemia. Rapid influx of serum calcium into bone in the immediate postoperative period may cause severe hypocalcemia, hungry bone syndrome, which is initially corrected by intravenous calcium gluconate 10 ml of 10%. It is due to the sudden drop in parathyroid hormone. Sudden drop हो गया क्योंकि हमने दोनों सारी पैराथायरॉइड निकाल दिए या डैमेज कर दिए आफ्टर सर्जरी की थायराइड की पैराथायरॉइड भी डैमेज हो गई, तो पैराथायरॉइड हार्मोन के सडन ड्रॉप की वजह से कैल्शियम ग्लूकोनेट को लगाना पड़ेगा आई. परमानेंट हाइपोपैराथायरॉइडिज्म इज रेयर 0.5 to 1%. Even though temporary hypoparathyroidism and hypocalcemia are common, 25% patients में temporary hypoparathyroidism हो सकता है, hypocalcemia, which is corrected well with calcium or for a certain period of 3 to 6 months. कैल्शियम को सपोर्ट करेंगे, कैल्शियम ओरली देंगे तो उससे जो है मरीज को ये हाइपोपैराथायरोइडिज्म और हाइपोकैल्शियमिया की जो प्रॉब्लम थी वो कंट्रोल हो जाएगी. External linear nerve injury is more common than recurrent linear nerve. There is a loss of extension in vocal cord causing reduced power and range in voice. ये हमें पोस्ट ऑपरेटिव पीरियड में जब मरीज बोलेगा उससे अंदाजा हो जाएगा कि इसकी वॉइस थोड़ी सी पिच कम हो गया है. Thyroid insufficiency develops in 25 to 45% of cases. It is conferred by doing serum T3, T4, TSH after second, third and sixth month. इससे हमें अंदाजा हो जाएगा कि थायराइड इंसफिशियंसी कितनी है. It will be controlled with the help of proper medication. तो पोस्ट ऑपरेटिव कॉम्प्लिकेशंस है. कॉम्प्लिकेशन ड्यूरिंग सर्जरी हो सकते हैं, इंट्राऑपरेटिव पीरियड में, जस्ट आफ्टर पेशेंट को शिफ्ट किया पोस्ट ऑपरेटिव रूम में, वहां पे कोई कॉम्प्लिकेशन होता है, या फिर डिलेड कॉम्प्लिकेशंस हो सकते हैं. इंपॉर्टेंट कॉम्प्लिकेशन हेमरेज. इट मे बी ड्यू टू स्लिपिंग ऑफ लाइगेचर. इट इज ऑफन प्रेसिपिटेटेड बाय मरीज ने पोस्ट ऑपरेटिव में विगरस कफिंग, रैचिंग इन द पोस्ट ऑपरेटिव. उससे क्या होगा, कभी कभी स्लिप हो जाता है लाइगेचर. इट कॉजेज स्लिप हो गया, हेमरेज होगा. इसके नतीजे में इट कॉजेज टैकीकार्डिया, हाइपोटेंशन, ब्रेथलेसनेस, ट्रैकियल कंप्रेशन. जो हेमाटोमा कलेक्ट हुआ है वो कंप्रेस करेगा ट्रैकिया को ड्यू टू प्रोग्रेसिव टेंशन हेमाटोमा formation in the thyroid fossa under the sutured staph muscle causing severe respiratory obstruction. इसके नतीजे में साइनोसिस, हाइपोक्सिया, रेस्पिरेटरी फेलियर एंड समटाइम्स कार्डियक अरेस्ट. टेंशन हेमाटोमा इज ऑफन मिस्ड. क्यों? उसके ऊपर सारी मसल्स को मिटाई कर दिया है ना, मसल्स को रिपेयर कर दिया है, मसल्स को अप्रोक्सीमेट कर दिया है. तो जो हमारी इंट्राहायोइड मसल्स थी वो हेमाटोमा को विजुअलाइज होने में रुकावट बनती है. टेंशन हेमाटोमा इज ऑफन मिस्ड इन द पोस्ट ऑपरेटिव वार्ड. Early identification of the problem with immediate bedside removal of the skin and deeper sutures prevents further compression of the trachea and relieves the respiratory obstruction. Later, patient is shifted to the operation theatre. अगर ऐसा हुआ है, first we will do bedside removal of the skin suture and staph muscle suture. After that, patient is shifted to the OT and wound is inspected under anesthesia. Bleeding vessels is caught and securely ligated. Often transfusion of the blood is also required. If bleeding ज़्यादा होगी, then we have to start transfusion. Second complication, respiratory obstruction. It may be due to either hematoma or due to laryngeal edema or due to tracheomalacia or bilateral recurrent laryngeal palsy or due to the trauma during the intubation. Evacuation of the clot and emergency tracheostomy also required sometimes in case of respiratory obstruction. If there is recurrent laryngeal palsy, it can be transient or permanent. During extubation, anesthetist should be asked to visualize the movement of the vocal cord to confirm that there is no recurrent laryngeal palsy or injury. Distressing changes in voice should be assessed and treated by steroid in case of neuropraxia, speech therapy and counseling. हुआ क्या, रिकरेंट लाइनिया हमने सेफ रखी है, लेकिन उसमें हैंडलिंग के नतीजे में जो न्यूरोप्रैक्सिया हुआ है, तो वी हैव टू एश्योर द पेशेंट, क्योंकि हमारे एनेस्थेसिस्ट ने एक्सट्यूबेशन करते वक्त देख लिया था कि वोकल कॉर्ड का मूवमेंट ठीक है, तो वी विल एश्योर द पेशेंट, डोंट वरी, योर स्पीच विल रिकवर विद द हेल्प ऑफ स्पीच थेरेपी एंड काउंसलिंग. एक्सटर्नल जो अगला कॉम्प्लिकेशन हो सकता है, नेक्स्ट कॉम्प्लिकेशन एक्सटर्नल लैरिंजियल नर्व इंजरी. एक्सटर्नल लैरिंजियल नर्व इंजरी रिकरेंट लैरिंजियल नर्व इंजरी से ज्यादा होती है, बहुत कॉमन. द एक्सटर्नल लैरिंजियल नर्व supplies cricothyroid muscle after passing through the cricothyroid space of reed is at risk during the thyroidectomy. तो उसी स्पेस में हमको अपर पोल को लाइगेशन करना था, वहीं पे ये नर्व पाई जाती है एक्सटर्नल नर्व, तो हो सकता है कि ये डैमेज हो जाए. अगर ये डैमेज होगी तो क्रिकोथायरॉइड मसल का फंक्शन डिस्टर्ब हो जाएगा, तो वोकल कॉर्ड का जो वोकल कॉर्ड का टेंशन है, जो उसका एडक्शन होगा, वो डिस्टर्ब होगा, जिसके नतीजे में पिच ऑफ द वॉइस विल बी डिस्टर्ब. This causes elongation of the vocal cord or flaccidity. Injury to this branch causes the inability to lengthen the vocal cord and creates a high-pitched sound. The external nerve is probably the most commonly injured nerve in thyroid surgery. आमतौर पे near about 2 to 25% तक केसेस में इंजरी हो जाती है. जो अगला कॉम्प्लिकेशन है, that is the hypothyroidism crisis. It is observed in thyrotoxic patient. Thyrotoxic patient था, before surgery pre-operatively we have not prepared properly. उसको euthyroid condition में लेके नहीं आए, उससे पहले ऑपरेशन कर दिया. Then there is chances of thyrotoxic storm is there. Thyrotoxic is potentially lethal. Up to 50% patient die. Thyrotoxic storm is potentially lethal and must be dealt with utmost care. It can be seen in toxic nodule or toxic nodular goiter, or more commonly in Graves' disease. Mortality is about more than 50%. There is an exacerbation. होता क्या है इसमें? Thyrotoxic storm में क्या होता है? Exacerbation of the hyperthyroidism with decompensation of the organ system. All of a sudden hyperthyroidism हो जाता है. Feature of thyrotoxic storm in the anesthesia patient include during surgery start हो जाता है कभी-कभी tachycardia, hyperthermia, और अब एक पेशेंट में पोस्ट ऑपरेटिव पीरियड में features of nausea, tremor, severe dehydration, circulatory collapse, hypotension, hyperpyrexia, out of proportion tachycardia, cardiac arrhythmia, and altered mental status. Cardiac arrest may also occur. If treatment is not adequate, patient may also progress towards the coma. To avoid this, we have to do proper pre-operative control of the thyrotoxic condition, or we will achieve first euthyroid condition, then we will proceed for the thyroidectomy. Intraoperatively अगर हो गया तो कैसे मैनेज करेंगे? First step in managing thyrotoxic crisis during thyroidectomy is to stop the procedure. पहले तो stop करो. Intravenous beta blockers start करेंगे, sodium iodine and steroids are administered to control the sympathetic activity, release of thyroid hormone and hyperthermia. Cooling blankets and cooling intravenous fluid are used to reduce the patient's body temperature. Oxygen demand increases dramatically during thyroid storm. So we will do the oxygen support also. Next complication है hypoparathyroidism. सारी पैराथायरॉइड ग्लैंड निकाल दी, थायरॉइडेक्टोमी के साथ साथ पैराथायरॉइड ग्लैंड भी निकाल दी, एंड और या फिर पैराथायरॉइड को इतना डैमेज कर दिया, उसकी सप्लाई को हैम्पर कर दिया, तो हाइपोपैराथायरॉइडिज्म एंड द रिजल्टिंग हाइपोकैल्सीमिया मे बी परमानेंट और ट्रांजिएंट. हमने उसमें इस्चीमिया किया है या ट्रांजिएंट डैमेज किया है, देन इट विल बी ट्रांजिएंट, ठीक हो जाएगा बाद में. इफ वी हैव डन परमानेंट डैमेज, then hypoparathyroidism or hypocalcemia may be permanent. Causes are direct trauma to the parathyroid gland, devascularization of the gland, removal of the gland during surgery. Surgery करे thyroid की parathyroid निकाल दिया. The rate of temporary hypocalcemia is reportedly 2 to 50%. The cause of transient hypocalcemia after surgery is due to temporary hypoparathyroidism caused by reversible ischemia to the parathyroid gland. Initially asymptomatic for 4 to 5 days, later develops सरकम ओरल नम्बनेस, पहले तो 4-5 दिन तो कुछ पता नहीं चलेगा, आफ्टर दैट मरीज कहेगा कि मेरे मुंह के पास थोड़ा सा सुन्नपन है। चेंजेस इन मेंटल स्टेटस, टिटेनी, कार्पोपिडल स्पाज्म, लैरिंजो स्पाज्म, स्पाइडर आना शुरू हो जाएगा, स्पाज्म आ गया उसके लैरिंग्स में, सीजर्स, प्रोलंगेशन ऑफ QT इंटरवल ऑन ECG एंड समटाइम्स कार्डियक अरेस्ट। So we have to manage hypocalcemia. Hypothyroidism, अगला कॉम्प्लिकेशन, नेक्स्ट कॉम्प्लिकेशन hypothyroidism is an expected sequel of total thyroidectomy. ये तो होना ही था, तो हमने थायराइड निकाल दिया है। In goiter surgery, the extent of thyroidectomy is controversial till now. The main goal of surgery is to prevent recurrent hyperthyroidism. ऐसा ना हो सर्जरी के बाद दोबारा से हाइपरथायरॉइडिज्म हो जाए, ये इंपॉर्टेंट है। हाइपो हो जाए नो प्रॉब्लम, वी विल मैनेज इट, लेकिन अगर सर्जरी के बाद में आफ्टर सर्जरी रिकरेंट हाइपर हो गया, hyperthyroidism, and it will be very difficult. So main goal of surgery is to prevent recurrent hyperthyroidism, because recurrent hyperthyroidism after surgery is more difficult to manage than permanent hypothyroidism. Because of this fact, total thyroidectomy recommended. Systemic thyroid hormone levels are low in hypothyroidism. It may be primarily due to thyroidectomy or radioactive iodine ablation, primary thyroid disease, or maybe secondary due to hypopituitarism, or tertiary due to hypothalamic disease. एक कॉम्प्लिकेशन जो बहुत इंपॉर्टेंट है, दैट इज द हंग्री बोन सिंड्रोम. इट अकर्स यूजुअली इन पेशेंट विद प्री ऑपरेटिव हाइपरथायरॉइडिज्म. पेशेंट प्री ऑपरेटिव हाइपरथायरॉइडिज्म था, अब सर्जरी होगी, इसके बाद क्या होता है, दे हैव इंक्रीज बोन ब्रेकडाउन इन देयर हाइपरथायरॉइड स्टेट. प्री ऑपरेटिवली ब्रेकडाउन हो रहा था, बोन ब्रेकडाउन हो रही थी, बोन डिसॉल्व हो रही थी. अब क्या हुआ, व्हेन ए पेशेंट thyroid hormone level drops acutely after surgery, the stimulus to bone breakdown is removed. The bones are now hungry for calcium. Removing, अब जो bone को जो है अब कैल्शियम चाहिए, तो bone start removing calcium from the plasma. Patients who have symptomatic hypocalcemia in the early post-operative period or whose calcium levels continue to fall rapidly need treatment. In symptomatic patients, intravenous calcium gluconate 10 ml of 10% solution is administered over 10 minutes. 1 to 2 gram of elemental oral calcium should be given each day. Calcium carbonate 1250 milligram provides 500 gram of elemental calcium, and we have to give 1 to 2 gram of elemental calcium. So the patient should take 2500 to 5000 gram per day. So we have to divide these doses in 2 to 3 times. Patient needs vitamin D supplementation with calcitriol 0.25 to 1 microgram per day. Right. अदर कॉम्प्लिकेशन जो है, जो रेयर होती है, एक तरह से इन्फेक्शन हो सकता है, या रिकरेंट थायरोटॉक्सिकोसिस हो सकता है, या माइनर कॉम्प्लिकेशन. इन्फेक्शन का जो कॉज होगा, आमतौर पे ब्लीडिंग हुई ऑपरेटिव साइड से, हेमेटोमा बन गया फॉर्मेशन, और अगर एट द सेम टाइम इंफेक्टेड सुचर मटेरियल इज देयर, then it may cause infection. In large malignant thyroid during thyroidectomy, injury may occur to esophagus also, which causes severe localized sepsis in the neck area. Malignant thyroid था, उसको डिसेक्ट करते हुए esophagus पास में है, उसको डैमेज कर दिया, तो वहां से फिर इन्फेक्शन ट्रेवल कर जाएगा इस थायराइड की जो थायराइड फोसा था, वहां पे भी चांसेस ऑफ डीप इन्फेक्शन. अगर ऐसा हो गया इन्फेक्शन, then we have to do pus culture, starting higher generation antibiotic, and we will do nasogastric tube insertion. अब उससे क्या होगा कि चांसेस ऑफ इंफेक्शन, फर्दर जो इंफेक्शन आएगा वो कम हो जाएगा, क्योंकि फुड मटेरियल nasogastric tube से जाएगा. And endoscopic identification of the injured area is needed in the management of this case. Usually they recover but may need to keep in nasogastric tube. Feeding can be done through the tube for a few weeks. Few weeks में जब हम फीडिंग करेंगे, तो जो esophageal इंजरी हुई है वो it will heal itself. Recurrent thyrotoxicosis हो सकता है, recurrent thyrotoxicosis difficult to manage. So nowadays total thyroidectomy is commonly done for toxic goiter thyroid. इसलिए अब क्या कि recurrent thyrotoxicosis बहुत difficult है इसको मैनेज करना, इसलिए अब कंसेप्ट यही है कि टोटल थायरोइडक्टोमी कर दी जाए. Management is a proper anatomical assessment of the residual thyroid tissue by using a residual isotope scan or MRI. अगर ऐसा हो रहा है ऑपरेशन के बाद, अब थायरोटॉक्सिक अगेन डेवलप हुआ, then we have to do radioisotope scan to see the condition of the thyroid tissue, कहाँ पे है उसकी साइट लोकेशन. Radioactive ablation of residual thyroid tissue or surgical re-exploration we can do radioactive iodine ablation, or we will do residual thyroid tissue surgical reexploration and complete removal of residual thyroid tissue on both sides. तो थोड़ा था हमने पार्शियल थायरॉइडोटोमी किया था या सब टोटल किया था, बचा हुआ टिश्यू है वो प्रॉब्लम कर रहा है तो उसको भी निकालना है। लेकिन ये थोड़ा सा जाहिर सी बात है, एक दफा हमने ऑपरेट किया है, दोबारा से फाइब्रोसिस हुई है, तो चांसेस ऑफ इंजरी to the nerves are more in re-exploration. It carries a higher risk of injury to the recurrent line nerve and parathyroid. So we will do meticulous dissection, adequate exposure, and proper retraction are needed in case of re-exploration. Minor complication है, small sarcoma बन सकता है, which can be left as such to resolve, अपने आप ही resolve हो जाएगा. Large sarcoma, small seroma, serous collection हो जाएगा. Large seroma बन गया है, then we will do repeated aspiration, और कभी कभी पुअर स्कार बन जाता है, स्कार में ग्रेनुलोमा बन जाएगा या थोड़ा सा उस पे स्कार में जो है कीलोइड बन सकता है, तो ये कॉम्प्लिकेशन है।
Thank you, Shakil bhai. MashaAllah, for a loud and clear voice you had. Allah has bestowed you with a clear voice, MashaAllah. Dear participants, if you have any doubts, you can clear. Hello.
जी, अस्सलाम वालेकुम.
Walaikum. Okay, I think there's no doubt, no participant has any doubts, and there's no one to come forward for any in this query. So this was a nice presentation, very interesting presentation by Dr. Muhammad Shakil. He very well explained the anatomy of the thyroid gland, which received appreciation from our participants through texts. He nicely explained the steps of operation and the dissection in detail, with focus on the ligation of the vessels and preventing the damage to the laryngeal nerves. And nicely, very well explained the complications and their management simultaneously. It was a nice presentation overall. And today's lectures are over now. Now it is time to thank our speakers, the guests, and the participants, today's participants, as well as the management and of the organizers of this program. For this vote of thanks, I will invite our colleague, Dr. Mahjabin Fatima, present vote of thanks. Dr. Mahjabin Fatima.
Assalamu alaikum. Am I audible?
Yes, ma'am. Walaikum assalam.
Okay. Assalamu alaikum to everyone. Honorable Director, NIUM Bangalore, Professor Abdul Wadood, sir. Respected HOD, Department of ILMUL JARAHAT, NIUM, Professor Sayyid Shah Alam, sir. Respected speakers, Dr. Manzoor Ahmad, Associate Professor in Department of ILMUL JARAHAT, ZBM Junani Medical College, Pune, and Dr. Muhammad Shakil Ansari, Assistant Professor, NIUM Bangalore, and all the respected participants. I, Dr. Mahjabin Fatima, Assistant Professor, Department of ILMUL JARAHAT, NIUM Bangalore, take the opportunity to put my gratitude into words. I extend my gratitude to our Honorable Director, Professor Abdul Wadood, sir, for giving the support and encouragement to organize this webinar. A special thanks to our speaker, Dr. Manzoor Ahmad, Associate Professor in Department of ILMUL JARAHAT, ZDM Junani Medical College, Pune, for enriching us with his profound knowledge on urolithiasis and its management despite of his busy schedule. I extend my gratitude and thanks to our colleague, Dr. Muhammad Shakil Ansari, Assistant Professor, NIUM Bangalore, for sharing his knowledge on thyroidectomy, its anatomy, what precautions we have to take during surgery, and post-operative complications and its management in detail. I extend my gratitude to our HOD, Department of ILMUL JARAHAT, NIUM Bangalore, Professor Sayyid Shah Alam sir, for providing immense support to make this webinar successful. I must thank to the organizing team for working hard for the past few days to make this event successful. I would like to thank to the IT team, NIUM Bangalore, for their unconditional and continuous support. I would like to thank all the participants for their presence and enthusiasm and for giving the valuable and encouraging comments during the webinar. Thank you everyone once again for making this event a great success. Assalamu alaikum.
Not audible.
हाँ, सिद्धू भाई आपकी आवाज
No, not audible.
Oh, okay. Thank you, madam. Am I audible now?
you are audible now.
Thank you, madam. Before leaving, I will request participants to fill up the feedback form. Feedback form has been sent to you, and it has been shared on this link also, and it has been sent to you on your respective emails. So please fill up the feedback form so that you will get the e-certificates of this webinar today. Thank you everyone for being here with us. We will be back inshallah with our fourth national webinar on ILMUL JARAHAT updates in next month, inshallah. So till then, stay safe. And the dates will be communicated for the next webinar separately. Till then, stay safe. Allah Hafiz, everyone.
Thank you very much.
Thank you, Manzoor bhai. Thank you.